So, welcome everybody. My name is Thomas Rösch. I think you're seeing Stefan Mielke, but we are sitting close to each other. And on behalf of Alessandro Repici, the co-founder of Endoscopy on Air, I welcome you cordially to this event. And before you watch again on June 3, this is a very important date because the first time the endoscopic community leaves their limited borders and joins with the experts, worldwide experts on eosinophilic esophagitis. And there I hand over the microphone to Stefan Mielke, and I wish you all a very fruitful evening and afternoon.
Thank you very much, Thomas. Good afternoon, everyone. On behalf of my co-chairman, Professor Edoardo Severino from the University of Padua, Italy, it's my great pleasure to welcome you to our symposium on eosinophilic esophagitis. My name is Stefan Mielke. I'm a gastroenterologist in private practice in Hamburg, Germany, and affiliated with the University Hospital Hamburg-Eppendorf, where Thomas Rösch is working. We are very grateful to be part of the Endoscopy on Air program today, and we'd like to thank Professor Rösch and Professor Repici for giving us this very unique opportunity. As far as I know, this is the first symposium in this educational platform exclusively dedicated to a specific disease, namely EOE. And given the impressive number of more than 1,000 participants today, this is certainly one of the largest EOE symposia that at least I have ever witnessed. Now, the focus of our symposium today is mainly the role of endoscopy in different stages of this chronic disease, including first diagnosis, follow-up, management of complications, and also the current status of advanced diagnostic techniques. And to be complete, we will also discuss the important role of histopathology and recent advances in medical therapy of EOE. Now, we are very happy to have an outstanding international faculty today with some of the world leading experts in EOE from Europe and the US. And we are particularly pleased that all of them responded immediately and positively to our invitation. Now, before we start with the scientific program, I would like to remind you that you can post questions and comments during the entire symposium, but please use the Q&A function and not the chat. The Q&A function works much better for us, for the moderators, to screen your questions and to make sure that we miss any important questions. So please do not hesitate to use this function, and we will be happy about this. Now, with that, I would like to welcome our first speaker, Alain Schöpfer from Switzerland. He's professor at the Department of Gastroenterology and Hepatology at the University of Lausanne. He has published and co-authored more than 100 papers on EOE, and one of his special interests in EOE is not only issues of diagnosis and disease cause, but also the challenge of assessing disease activity. And to say the least, he's basically the inventor of the ESI Pro score that we are using today in clinical trials to assess clinical activity of this disease. So today, Professor Schöpfer will talk about the role of endoscopy in diagnosing EOE, and he will address specifically the questions who, when, and how. Alain, please. We look forward to your presentation.
So thank you, Stefan, for the kind introduction. First of all, I would like to thank the organizing committee for the kind invitation. I would also like to thank all the participants for this interest to participate in this exciting symposium. It's a true honor and pleasure for me to be part of this esteemed faculty and have the chance now to give the first presentation. Stefan, can you just give me a short feedback that you see the slides and technically everything is okay? Okay, so I take that as a yes. So yes. My role, thank you, Stefan, is now to talk about the role of endoscopy in diagnosing eosinophilic esophagitis. Here you see my disclosures. None of it influences the content of this presentation. So I was asked to cover the different topics. First of all, what are the endoscopic manifestations of eosinophilic esophagitis? How can you classify them? What should you be particularly attentive when taking biopsies from EOE patients? Then we will also have a look into the controversially discussed relationship between endoscopic features, histology, and and patient-reported outcomes, symptoms, and quality of life. And then we will also mention some of the pitfalls when doing the assessment of endoscopic activity of EoE. Let's first dive into the definition of eosinophilic esophagitis. Given the fact that I have the pleasure to be the first speaker, I include some basic slides about eosinophilic esophagitis just to make sure that we are all on the same page. It's possible that, particularly with respect to natural history, you will see these or similar slides by other speakers to follow me. So EoE is defined as a chronic local immune-mediated esophageal inflammation, and the diagnosis is based on 3 diagnostic pillars. You see already easily that endoscopy is not part of these 3 diagnostic pillars. So it's first of all symptoms of esophageal dysfunction. Second diagnostic pillar is a histology with the eosinophil predominant inflammation, and the third diagnostic pillar is exclusion of other conditions that might be associated with esophageal eosinophilia. As you're all aware, the leading symptom in the adolescent and adult population is dysphagia, so trouble swallowing, whereas the symptom presentation in the pediatric cohort is much more variable. So here we cover the histologic pillar. You see that this is a biopsy from the esophageal epithelium that is typically devoid of any eosinophils, and you here see easily more than 50 of eosinophils per 400-fold magnification. And the magic cutoff that has been chosen to allow us an EoE diagnosis is if you have 15 eosinophils and more per 400-fold magnification, then you can make the diagnosis of eosinophilic esophagitis. Differential diagnosis of other disorders that might be associated with esophageal eosinophilia. On top of the list, you see gastroesophageal reflux disease. The prevalence of these conditions is quite important. At least 20% of the westernized population suffer from reflux. So you can also expect that at least 20% of your EoE population will suffer from reflux. And of course, it can influence concomitant GERD, the endoscopic appearance, but also the histologic appearance of your EoE patients. Then other conditions that might be associated are particularly esophageal infection, but overall they are relatively rare. So what we know from pathogenesis, it's clearly a food and allergy-driven disorder where you have food allergens in the majority of these patients, notably to milk proteins, wheat proteins, eggs, and soy are also important allergens, and also aeroallergens might play a role. There is some problems described in the esophageal barrier function that might facilitate the entry of these food or aeroallergens into the esophageal tissue. Thereby, they are metabolized by dendritic cells and then presented to lymphocytes that produce many interleukins, among others, interleukin 5 and 13, that promote the maturation of the eosinophil precursors from the bone marrow. And by the expression of the eotaxin 3 receptor, the eosinophils are then lured into the esophageal epithelium where they degranulate, and their cytotoxic granules cause local tissue damage. And one important cytokine, the TGF-beta, activates fibroblasts for the deposition of extracellular matrix, which consecutively leads then to these stricturing complications. And this is now the next aspect. The natural history of untreated EoE is really marked by progressive deposition of fibrotic tissue that leads to narrowing of the esophageal caliber, as elegantly shown here in this review article by Dellen and Hirano. You start with a normal esophageal caliber, and then deposition of eosinophils, particularly in the epithelial layer, and progressively increase of the subepithelial layer that will reduce the esophageal caliber and thereby also cause progressive symptoms, dysphagia, up to food infections. Now, after this couple of introductory slides, I would come to the main topic I was asked to present to you. So how can we assess the esophageal features of eosinophilic esophagitis, and their really groundbreaking work has been done by the team of Ikoiran from Northwestern Chicago, who published this paper already in 2013 with the major endoscopic features. I first would like to draw your attention to the features that are described on the left-hand side of this slide. You see that he described fixed rings, whitish exudates, furrows, edema, stricture, and also some minor features with feline esophagus, which describes the transient esophageal rings, then narrow caliber esophagus and crepe paper. And I think it is important now to understand what was exactly done. So he took 25 videos from EOE patients and distributed them to an international group of EOE experts, and then he let them rank according to this first list you see on the left-handed side, the presence and also the severity of these distinct endoscopic features, and then he observed, analyzed the inter-observer agreement on these distinct features. And this is now on the right-hand side, the final list of items that remained in this classification system. So we remained with fixed rings, exudates that are scored from 0 to 2, furrows, scored from 0 to 1, edema 0 to 1, and also stricture 0 to 1. And then minor features, crepe paper made it. And you also see that other features, like for example, the feline esophagus, didn't make it just because their inter-observer agreement was not good enough. And one other feature you see here, for example, the edema that was initially graded from 0, 1, 2. Obviously, it was very difficult to make the discrimination between 1 and 2. So that's why it was collapsed to 0 and 1. And so let's dive now into these different endoscopic features. So here the exudates, it's really inflammatory features. Histologically, these whitish exudates correspond to eosinophilic microabscesses. I'm sure Dr. Collins will talk more about that. And so you see here the mild exudates that cover less than 10% of the esophageal surface, and here severe whitish exudates that cover more than 10% of the esophageal surface. Second feature, the ring, mild rings you see here, moderate rings defined as rings that do not really prevent the passage of the diagnostic endoscope, which typically has an outer diameter of about 8 to 9 millimeters. And then severe rings are defined as rings that do not permit anymore the passage of the diagnostic endoscope. Then edema, this is the original version where you see normal esophageal mucosa, here mild edema and severe edema. And you can already see that it's probably a bit difficult to make the discrimination between mild and severe. This was also the reason why the inter-observer agreement was relatively poor, and edema was just collapsed then in the definitive version of this grading system to either absent or present. Now the furrows describe longitudinal lines, which you see here. It's a bit similar to tram lines, and they are basically provoked by the upfolding of the mucosa due to the edema. You see here mild and severe. Also here it was relatively difficult to discriminate mild from severe. So in the definitive version, they are also collapsed into present versus absent. Now this initial feature of transient esophageal rings, feline esophagus, it's particularly during retching when you should see that or can see that. And upon full air insufflation, what you typically observe is that these rings disappear. Also here, it was difficult to have a good inter-observer agreement. So this feline esophagus didn't make it into the final inclusion of the different criteria. You remember that crepe paper, which basically describes mucosal fragility, didn't make it into the final criteria. What happens is that if you pass your endoscope through an existing stricture, then you see these superficial lacerations that let you look directly on here to the circular muscle layer. Of course, this is not a feature you can always observe, but only if you have a stricturing disease. And so to conclude, please remember these 5 different distinct features. So we have inflammatory features with whitish exudates, we have edema, we have the furrows, and we also have fibrotic features with rings and strictures. So this was the first description, and you can imagine that it's relatively easy also in daily clinical practice just to describe the esophagus according to these different endoscopic features. The second step was now to evaluate, can you use this grading system also as a scoring system? So if you want to assess now change, let's say you do an evaluation of a new anti-eosinophil drug and you want to assess before treatment and then after treatment if also the endoscopy improves, can you also use it as a score? And this international group basically evaluated 3 scores. So the first one was just graded from 0 to 8. If you count here all these distinct points together, you see here that you have a score from 3, 5, 6, 7, 8, from 0 to 8. And if you just count these scores together, you already have a first score. Then there was also other scores evaluated that took into account the endoscopist's grading to distinct endoscopic features on a score from 0 to 10. And what you can see is that these 5 expert endoscopists, they particularly put more weight into severe rings, strictures, and also exudates, but they attributed less weight to the presence of furrows, edema, and also crepe paper. And then what was finally done in a trial using oral fluticasone tablets is that these 3 different scores were evaluated. And what I can tell you is that the simple score from 0 to 8 performed just similarly to these scores that were weighted. I think that's good news. So EREFs can be used as a score from 0 to endpoints, and stratifying now EREFs into separately proximal and distal esophagus does not provide you with better score responses when you assess now the efficacy of an anti-eosinophil treatment. I think that's reassuring news that this score is relatively easy to be used also in the framework of randomized controlled trials. The international EOE community went one step further, and here I would like to show you the results of an article that is just in press now in GI endoscopy on the leadership of Eco and Chris Marr from Alimentiv. Different scores again were evaluated. Here you see the original EREF score from 0 to 8, a very simplified version that only ranked from 0 to 5, and then an expanded score from 0 to 9 and even 0 to 11. And what I can tell you is that the simple original EREFs, but also the expanded score, they showed to have quite good test performances in a review of randomized trial, and so they can all be used to assess endoscopic change in randomized controlled trials. Now, after having talked about the distinct endoscopic features, we come to biopsy sampling. What should you take care of? I think the key message here to retain is that we should take at least 6 biopsies from different locations. And of course, if you see now particular endoscopic features such as white exudates, then you should direct your biopsy forceps to these regions, because like that you increase your diagnostic yield. So early work from the group of Nimi Gonsalves from here, Chicago, has shown that we have a diagnostic accuracy that surpasses 95% if we take at least 5 esophageal biopsies to diagnose eosinophilic esophagitis. Now, the relationship of endoscopy with patient-reported outcomes and also histology. This is a controversially discussed topic. And here I would like to use an analogy that is frequently used also when talking about the similar aspects of outcome assessment in inflammatory bowel disease, such as Crohn's disease and ulcerative colitis. There, for example, you're aware, if you look now at 100 patients in clinical remission with Crohn's disease, defined as a CDR of less than 150 points, and you systematically do an endoscopic assessment. In these, in about 50% of the population, you will have persistence of ulcerations. So meaning that symptoms in Crohn's disease are not at all predictive for endoscopic activity. And unfortunately, we have a relationship that is a bit similar in eosinophilic esophagitis, in a sense that absence of symptoms does not really exclude with a good certainty ongoing endoscopic and or histologic activity. On the right-hand side of the slide, I show you how different outcomes in eosinophilic esophagitis should be assessed according to the regulatory affairs demands. So this is basically based on recommendations from US FDA and also the European Medicines Agency. We should strictly separate the assessment of patient-reported outcomes, symptoms, and quality of life from everything the physician can assess, like endoscopy and histology, in order to exclude any potential bias by a physician in the peer role. And so if you evaluate now this relationship between symptoms and endoscopic and or histologic activity, then we unfortunately had to find out that we are a bit confronted to a similar problems like in IBD, in a sense that about 1/3 of EOE patients in clinical remission, as measured by the ESI-Pure instrument, showed ongoing endoscopic and histologic activity. And so I think this is a very strong argument that we see these patients on a regular basis also for an endoscopic and histologic workup, even if they tell you they are completely asymptomatic. With respect to the relationship of endoscopic features and histology, there the relation is clearly better. You have a highly significant correlation between the esophageal peak eosinophil count and the endoscopic inflammatory features such as whitish exudates, furrows, and edema. Of course, you do not really expect of having a significant correlation with the endoscopic fibrotic features, so you do not really see that with rings and stricture. But if you take the overall endoscopy score, just EREFs from 0 to 8, then the relationship between endoscopy and peak eosinophil counts is highly significant. Now let's talk about pitfalls on the way to make a proper endoscopic assessment. So the first case may be that endoscopy is completely normal in a symptomatic patient. What do you do then? So this is taken from the EOE guidelines in UEG, and you see here that with the increasing prevalence and incidence of eosinophilic esophagitis, it becomes much more frequently encountered also when doing an endoscopic assessment. And in fact, it's now nearly 50% in all patients who present with dysphagia and food impaction. And if you look now into the literature, then it's said that endoscopy is normal in about 20% of the EOE patients. I think main message here is to take biopsies in symptomatic patients, even if their endoscopy is normal. Another issue might be that if you look now into the classification of the distinct endoscopic features, of course, there is an inherent overlap of rings and strictures. If you look now into rings with grade 3 that do no longer permit the passage of your diagnostic endoscope, of course, then you will have a stricture present. So somehow you assess the same phenomenon twice. Third issue is that our accuracy in judging now the esophageal caliber just by eyeballing is relatively limited. So we are probably bad assessing the substenosis that measure 12, 13, 14 millimeters that can already cause symptoms. And so there is some literature already out there that it's worthwhile trying to achieve an endoscopic diameter of at least 17 millimeters in order to reduce the occurrence of these food bolus infections. And I think one of the tools that might have a future for assessing minimal esophageal caliber is this tool by Ovesco. So the bougie cap, it's basically a simple hard plastic cap you can mount on the tip of your endoscope. I think the big advantage is that it doesn't cost too much. So it's roughly 60 euros. And like that, it's much cheaper than the through the scope balloons that cost about 300 euros. Another issue might be that reflux might contribute to the endoscopic appearance in the distal esophagus. Here I show you this complex relationship. So it's not always pure eosinophilic esophagitis, but there is a complex relationship. You can imagine that you have an untreated eosinophilic esophagitis. Also, the esophageal clearance function might be impacted, so you can worsen reflux disease. And on the other hand, untreated reflux can also worsen underlying eosinophilic esophagitis by facilitating the entry of food allergens into the esophageal layer. So in case of doubt or in case of clear presence of concomitant GERD, you have to treat two conditions. Another pitfall might be that it looks endoscopically like EOE, but the histologic criteria are not fulfilled. There we have to talk also a bit about the subepithelial layer. So in the last majority of cases, we have like a gradient with higher eosinophil levels in the epithelial layer and lower values in the subepithelial layer. Rarely you have a pretty much the same amount. And, you know, of the 1/3 of cases, you have predominant eosinophilia in the subepithelial layer. So here you might potentially miss the diagnosis by taking esophageal biopsies only. And I think the way to get out of this dilemma is to take deep esophageal biopsies, so bite on bite. This study shows you different biopsy forceps models that were evaluated for the accuracy, also to provide you with subepithelial tissue. Unfortunately, these two first side opening cutting cup forceps are no longer on the market. It was very impressive because they had a diagnostic yield of more than 90% in providing subepithelial tissue. And on the right-hand side, you see the orange forceps that is typically used, large capacity forceps with alligator jaws. There you have in about 55% of all the biopsies subepithelial tissue. So I think that's an important message. In case the histologic cutoff is not met at first time, you do not have your 15 eosinophils in histology, do the endoscopy again, repeat it, and take deep biopsies from the subepithelial layer, because it might be a case with a predominant eosinophilia in the deeper wall layer. And I was also asked to talk about this new entity that just has been published by an international group under the leadership of Thomas Gruter, where a new entity was described, the so-called EOE-like disease. It's basically patients that present with typical symptoms of esophageal dysfunction, but the histologic cutoff is not met. So it was on an international level, roughly 70 patients were collected, quite a profound workup that was done also with systematic sequencing of these patients. And about half of these patients were then classified as EOE-like esophagitis, 1/4 as non-specific esophagitis, and 20% as lymphocytic esophagitis. And what is now interesting, this is still unpublished result, is that this EOE-like disease might evolve into the real deal EO. So it might be like a early phase of eosinophilic esophagitis that needs further observation, and that might evolve into real deal EOE. And this is just another differential diagnosis. Not everything that looks like eosinophilic esophagitis is eosinophilic esophagitis. Keep in mind differential diagnosis. In this case, it was esophageal lichen planus. And with that, I'm already at the end of my presentation, and I would like to highlight the key points that I was able to identify on endoscopic assessment in EOE, take esophageal biopsies in symptomatic patients, even if the endoscopy is normal, take deep biopsies if histologic cutoff is not met at the first time, use EREFs as a grading system also for daily routine. It's really easy to do and even facilitates the writing of your reports. Use EREFs also as a score for clinical trials. Personally, I think that the simple EREFs from 0 to 8 performs just fine. Do endoscopic and histologic follow-up regularly, even if in asymptomatic patients. We have looked into this controversial relationship between PRO and biologic activity, and EOE-like disease, just as recently described, might develop later into real deal EOE. So if you do not meet your histologic cutoff at the first time, deep biopsies don't provide you with the answer, see these patients again. And keep in mind also existence of diseases with similar appearance to EOE. With that, I'm already at the end, and I'm happy to discuss now your questions.
Thank you, Alain, for this excellent presentation and also the very nice key point messages at the very end. You highlighted the pitfalls that we often encounter in diagnosing EOE very precisely. And let's see, we have 2 questions in the Q&A section. And the first one is the question, is grading only, so I guess this relates to EREFs grading, only practice in the Europe or internationally?
So I think it's practiced internationally. So I used it relatively early on, and I can tell you it really facilitated the writing of my endoscopy rods and also the speed with which I can do it. Because you can just say, let's say, X1 R0 E1 F1 S0, and then you know exactly what happens in the esophagus. And like that, you avoid spelling out all the distinct endoscopic features. I really think it's easily to be used in daily clinical practice. And it also allows you to trace in the follow-up of these patients what is now the improvement of the endoscopic aspects under different therapeutic regimens.
Yeah, I will really support this to use the score. I do it the same way like you, because we also learn to speak in the same language, because different terms are used and there are no gradings used or whatever. But the problem is, at least in Germany, in my experience, we did a survey here. We learned that about half of the gastroenterologists in Germany don't know EREFs, and the other half have heard about EREFs but don't use it in clinical routine. This was a few years ago, but I think we have to work on this to promote.
So I think this will dramatically change now after this symposium. Just one little comment, Stefan, the only modification I do from the original EREFs is the white exudates. I write in percent how much percent of the esophageal surface is affected. So for example, is it 30%? Because it helps me in the long-term run to understand better what's now the efficacy of a particular treatment.
Okay, there are a couple of questions in the Q&A now about treatment, steroids, etc. I would move this, or I would ask the participants to wait with the answers, because we will address this later on. But here's another question for you. When dilation is contraindicated in EOE?
So if you agree, dear Stefan, I will keep this question for Evan, because it will be Evan talking, really focusing on dilation, and he has an excellent presentation. Please hold on, and he will answer all your questions about dilation.
Okay, so all the questions that I do see now are referring to treatment and steroid treatment. Here's one. Is taking esophageal biopsy technique taken let me see, taken same as in EOE? I'm not really getting the point of this question.
It's about the technique to take the biopsies.
The technique to take the biopsy in EOE. Do you have special recommendations how to take?
So what I typically do is that the forceps comes tangentially onto the esophageal wall. I typically suck out the air to create like mucosal folds, and that the mucosal fold falls into the forceps. And like that, I have quite good tissue samples. So I think the easiest recommendation would be, do not try to take good esophageal biopsies with fully inflated esophagus, but deflate and you will have better tissue samples.
Okay, here I have two more related to endoscopy. What is the average number of endoscopies for these EOE patients before finally being diagnosed in your experience?
So we know that unfortunately the diagnostic delay that is defined as the time interval that passes from first EOE-related symptoms until the diagnosis is made, it's about 5 years in Europe and also United States. Now, Stefan, I don't know what is now the average number of endoscopy, I have to admit.
Okay. This question I think is very important. From where do you take biopsies and on PPI for how long? So the one part of the question is, do you prefer that patients are on PPI before the first endoscopy, I guess, or off PPI?
I typically like to see them off PPI, so like natural state, because we know that PPI can also reduce eosinophil counts in about 1/3 of patients. So I prefer to have them untreated.
Okay, thank you. So there are much more questions coming in, but we are running out of time. So thank you, Alain, for your presentation and the great discussion. We will try to answer all the questions that remains open, referring to endoscopy later on. So don't worry. And then we will move on in the program. Thank you, Alain, again. And I will hand over to Eduardo.
Thank you, Stefan, and thank you, Alain. I think that we started very brilliantly with the presentation of Alain, and now is the time of the next speaker, that is Professor Margaret Collins. She's the director of the Division of Pathology and Laboratory Medicine, Cincinnati Children's Hospital Medical Center, University of Cincinnati College of Medicine in Cincinnati, Ohio. She published more than 200 papers on different topics, but for sure, including eosinophilic esophagitis and other eosinophilic gastrointestinal disorder. She has the opportunity to measure histologically, talking the same language using the histologic score she developed, and we are currently using in observational and also in randomized control trial. And so it's my pleasure and honor to introduce you, Margaret Collins. She will talk us about the histopathology of EOE, just counting eosinophils. Please, Margaret.
Thank you very much, Dr. Severino, for your very kind introduction. And I certainly have a high bar to maintain with the excellent talk by Dr. Schofer. And thank you again to the organizers of the webinar for allowing me to be here, and to all of you for being here as well. These are my disclosures, and they don't impact the following talk. So in the early 1990s, we began to differentiate this new disease, eosinophilic esophagitis, from the one disease that affected the esophagus as we thought at the time, gastroesophageal reflux disease. And as we'll see with the studies that are cited on the next few slides, pathology studies focused on peak eosinophil count as the hallmark of eosinophilic esophagitis to distinguish it from GERD. But virtually all of them, at least in passing, mentioned other histologic abnormalities. And we'll see that from the beginning, grading and staging and special stains were part of the pathology evaluations. So this first study cited here mentioned numerous intraepithelial eosinophils in the esophageal mucosa of patients who we now know had eosinophilic esophagitis, but also measured actually the depth of the thickened esophageal layer, evaluated papillary elongation. Both of those are features of gastroesophageal reflux disease. Used a Giemsa stain to evaluate for mast cells, and also evaluated gastric and duodenal biopsies, which helped to stage the disease. In this second publication here, the authors mentioned the numerous intraepithelial eosinophils in their cohort of eosinophilic esophagitis patients, but also mentioned microabscesses. And this third paper actually included the first eosinophilic esophagitis grading system that included evaluation of inflammatory cells other than eosinophils, such as neutrophils, which occur in gastroesophageal reflux disease. Also evaluated were erosions and ulcerations, which we now know are much more common in GERD than they are in EOE, as well as the vascular pegs, as they were called, and the thickness of the epithelium. This was called a grading system, but the evaluation of the inflammatory infiltrate was actually staging, because it depended on how much of the epithelium was inflamed. These two publications from the mid to late 1990s both concentrated mainly on intraepithelial eosinophils, but both also mentioned basal zone hyperplasia. And so to determine if the word hyperplasia was actually correct, a study was done using an antibody to cells that are not in G0. So all phases of the cell cycle except the resting phase. And numerous nuclei in these biopsies from active eosinophilic esophagitis stained with the antibody, and a biopsy obtained following swallowed corticosteroid therapy, the nuclear staining was much reduced. And in a biopsy from a subject who did not have eosinophilic esophagitis at all, there was hardly any staining. So this corroborated that the word hyperplasia was actually a good word to be using to describe the thickened epithelium in eosinophilic esophagitis. And finally, this paper in the late 20th century added a description of eosinophil surface layering to the features associated with eosinophilic esophagitis. This lovely immunohistochemical study from the early 21st century essentially established eosinophilic esophagitis as a or helped to establish eosinophilic esophagitis as a Th2 disease. An antibody to eosinophil cationic protein brought out the eosinophils here compared to normals. Antibodies for T cells and mast cells showed that they were increased in eosinophilic esophagitis. IgE was detected in likely inflammatory cells. Abundant TNF-alpha was found in epithelial cells in biopsy from someone with eosinophilic esophagitis, and IL-5 was identified in inflammatory cells. Now, IL-5 was already known to be important in atopic diseases, and so it seemed prudent to test it as therapy for eosinophilic esophagitis. And in this study, using an anti-IL-5 antibody, mepolizumab, to treat eosinophilic esophagitis in children, the pre-therapy mean eosinophil count in esophageal biopsies was 39.1, and after therapy with mepolizumab, it dropped to 9.3, which was statistically significant. So this helped to establish that, in fact, IL-5 is important in promoting the presence of eosinophils in the tissue in eosinophilic esophagitis. In addition, abscesses, and big and small abscesses, were resolved at the end of therapy with the anti-IL-5 antibody. However, basal zone hyperplasia showed a low rate of resolution, and a current study in press with a different patient population, adults who have hypereosinophilic syndrome, with GI involvement, treated with benralizumab, which is an antibody to the IL-5 receptor, they found that the GI eosinophils were completely depleted. But in the esophagus, although the basal zone hyperplasia was improved, it was persistent, suggesting that there are other forces at work and that the presence of those other changes are not due entirely to IL-5. This landmark study from the early 21st century identified an EOE transcriptome, and that the gene that was most upregulated in that transcriptome was the eotaxin 3 gene. And this in situ hybridization study here shows with these little black dots that most of the mRNA for eotaxin 3 is expressed in the epithelial cells, again, of active esophageal biopsies from patients with active EOE. So to try to understand the genesis of the transcriptome better, another substance known to be important in atopic disease, IL-13, was studied, and it was found that the mRNA is markedly elevated in EOE biopsies, that IL-13 induces the EOE transcriptome in cultured esophageal epithelial cells, as well as inducing production of eotaxin 3 from those cells, that IL-13 downregulates desmoglein 1, which interferes with the epithelial barrier function of the squamous epithelium, and a transgenic mouse model of IL-13 was associated with thick epithelium in the esophagus. And the interesting thing here is that the mouse was transgenic to express IL-13, overexpress IL-13 in the lung. And yet this happened in the esophagus, as well as numerous eosinophils infiltrating the esophagus. And the really interesting thing was the epithelium again was thickened in a different mouse who was eosinophil deficient, suggesting again that there were additional forces at work in the pathology of eosinophilic esophagitis. And so this study of dupilumab, an antibody to IL-13, that is actually an antibody to the receptor, to the IL-4 receptor that blocks IL-4 and IL-13, found that following therapy, the change in the peak eosinophil count was much greater in patients who had received the drug compared to placebo. And the same was true for evaluating the scores that evaluated additional features such as basal zone hyperplasia, microabscesses, surface layering, and so on. So there are numerous reasons to define pathology of a disease, and in order to provide a template, hopefully, for uniform evaluation, another scoring system was developed that evaluates 8 features in esophageal biopsies from patients who were thought to have eosinophilic esophagitis. So the bar here demarcates really marked basal zone hyperplasia. The nuclei are perpendicular to the lumen instead of being parallel to the lumen, and they're very close together, much more close together than they should be. The arrows are pointing to intraepithelial eosinophils, and if you strain a little bit, you'll see that there are lots of those. The arrowheads are pointing to spaces between the cells that ought not to be visible, dilated intercellular spaces. The asterisks are demarcating fibers in the lamina propria. There should be little fibrils, thin wisps of collagen, not thick ones. The asterisk here is showing an abscess that is associated with destruction of the underlying tissue, which is by definition what an abscess is. And here is surface layering demarcated by the arrows. The arrowhead here is pointing to surface epithelial alteration, which is a change in surface epithelium that makes it pink, more pink compared to the rest of the epithelium due to an abundance of keratin in that part of the epithelium. And finally, dyskeratotic epithelial cells here at the arrows. So this scoring system evaluates those 8 features for grade and severity as a grade score and extent as a stage score on a 4-point scale, with 3 being the worst. It behaves the way that you want a scoring system to behave. It is responsive, meaning that as the peak count, eosinophil count goes down, the scores go down. As the peak eosinophil count, which is still the gold standard for the pathology part of the diagnosis of EOE, As the peak eosinophil count goes up, the HSS scores go up. It's reliable, meaning it can be used by pathologists other than those who made it up. This recent study points out that it's more reliable in pathologists who are experienced compared to those who are just starting out, which means we need to teach our residents in pathology better about esophageal pathology. The scores have meaning. They correlate with symptoms, with endoscopic features, with IgG4 levels, with the eosinophil progenital levels, and with endotype. A recent publication says that the scores distinguish EOE from GERD. However, the biopsies that from GERD patients in the study did not have a lot of intraepithelial eosinophils. It would be a better study to compare the EOE HSS scores from EOE and patients who have GERD, who have the small subset of patients with GERD who have abundant intraepithelial eosinophils, to see if it distinguishes between the two. Basal zone hyperplasia and dilated intercellular spaces may persist in patients whose eosinophil inflammation is significantly diminished or is not there after therapy, suggesting that they may be suitable targets for therapeutic intervention to reduce symptoms. Surface epithelial alteration and dyskeratotic epithelial cells predict the presence of one of the other features of the scoring system, something that never would have occurred to me. I didn't do this work, but they predict the presence of lamina propria fibrosis. Change in surface epithelial alteration, the pink surface correlates with change in epithelial mesenchymal transition that happens at the lamina propria epithelial interface, suggesting again that there's some relationship between what goes on at the surface and under the surface of the epithelium in esophageal biopsies. Dilated intercellular spaces have been shown to negatively correlate with esophageal mucosal impedance, and they may facilitate the passage of antigens such as gliadin. And finally, basal zone hyperplasia and lamina propria fibrosis correlate negatively with T-span12, which is the gene most dysregulated, and it's downregulated in fibrostenotic EOE. So where I think we are and where I'd like us to be and to keep along this track is relating form and function. So we've seen that DIS and may correlate, it does correlate with abnormal mucosal impedance and facilitates antigen passage into esophageal epithelial cells, between esophageal epithelial cells. Surface epithelial alteration is really like a callus on our hands or on our feet. It is a protective mechanism, and it may alter the normal transepithelial permeability across esophageal epithelium. Dyskeratotic epithelial cells may be markers for esophageal dysmotility, for esophagi that are or will become dysmotile. It seems to me to be intuitive that when there is abundant epithelium, as in really hyperplastic epithelium, that produces eotaxin 3 and TNF alpha, and eotaxin 3 is the major drawer of eosinophils out of the vasculature and into tissue. That given the right circumstances, having that epithelium around is a source for for changes that might promote eosinophilic esophagitis. So better not to have it than to have it, I would think. So relevance of grade and stage, dichotomous evaluation of the pathologic features that have been demonstrated is adequate for clinical work, but it doesn't tell you whether there is improvement or lack of improvement following a therapeutic intervention. So numerous eosinophils are present along with basal zone hyperplasia, and dilated intercellular spaces may well be a true and somewhat accurate description of an esophageal biopsy. But it's a very different description from peak eosinophil count is whatever it is. Most high power fields appear to contain more than 15 intraepithelial eosinophils. And if that's true, you can see it at low power. It doesn't take a lot to get that information. And both marked basal zone hyperplasia and markedly dilated intercellular spaces are seen diffusely. It would be even better if it was followed by the current biopsy appears significantly worse compared to the immediate previous biopsy, or significantly better as the case may be. But just that sentence alone gives a lot of information about grading and staging without using those words. And numbers can be substituted with words. A grade 1 could become mild. The language between the gastroenterologist and the pathologist could be mild. Grade 2, moderate. Grade 3, marked, and same for stage, and even collapsed a little bit. 1 and 2 could become mild and moderate, and then marked would be a different word used in the pathology report. But I think communication between gastroenterologist and pathologist is critical to have path reports that are as clinically relevant as possible. Excuse me. There we go. Also, I love this website. I go here to play on a bad day. This is what I was referring to before. Surface epithelial alteration and dyskeratotic epithelial cells predict lamina propria fibrosis. At that website, you can enter first the subjects, the real or imagined subjects' age, and then scores for basal zone hyperplasia, surface epithelial alteration, and dyskeratotic epithelial cells. And if the scores are very low, there's only one really that's above 0 here, which I made up. In a 10-year-old, the probability, either grade or stage, for having lamina propria fibrosis in that scenario is quite low. In a 50-year-old who has marked basal zone hyperplasia, moderate surface epithelial alteration, and dyskeratotic epithelial cells seen, the probability is much higher that there is lamina propria fibrosis. And I so loved Dr. Schofer saying that we need to get deeper biopsies. We really do. On this side of the Atlantic, most of the time we don't have any lamina propria attached to the esophageal biopsies. And then a good part of the time when the lamina propria is there, it's so crushed that we can't really evaluate it. So this is potentially a very helpful tool for evaluating lamina propria fibrosis. There's been almost no work done on remission in eosinophilic esophagitis. In a single institution study of a small cohort of children, but a very well-defined cohort of children, we found that the scores using the PEAS version 2.0 instrument for measuring symptoms, which is a validated instrument. We found that the total scores and the scores for 3 of the 4 domains in patients whose biopsies showed remission were significantly reduced compared to those who did not show remission. And it's not here, but other things were significantly reduced, such as the gene that's most upregulated, the mast cell gene most upregulated, and the EOE transcriptome. That expression was markedly reduced in remission compared to non-remission. And the grade stage scores here are very low for a remission score. So special stains in EOE, we've seen what they can do, how they can help to validate both in vitro and animal model data. I don't like a trichrome stain. I think it's misleading. Not all blue is bad. Collagen is part of the structure of the human body, and normal collagen stains blue. Immunohistochemical stains can be really helpful. Immunofluorescent stains are used by every researcher in the world, but I don't see a role for them in the clinical evaluation for eosinophilic esophagitis. Maybe the most important special stain, if you're going to do one, is for tryptase. There's so much coming out now about mast cells and their relationship with eosinophilic esophagitis. And I draw your attention to just one new finding recently, that mast cells relate to pain scores in patients who have eosinophilic esophagitis. I couldn't resist this. Edema, I think, is due to basal zone hyperplasia, edema in the EREF score. I think they go together. Rings, I think, are due to contraction of the inner circular muscle layer of the muscularis propria. Exudates, surface epithelial alteration, because some of those alterations are a lot actually of eosinophils associated with them, or eosinophil surface layering without epithelial alteration. Furrows, I think that as the higher grade furrow, I think the dome is due to basal zone hyperplasia, and the trough is due to contraction of the muscularis mucosa, of the esophagus, which is a longitudinal muscle layer. And strictures, I so look forward to the day when we'll be able to evaluate the muscularis propria and submucosa microscopically, maybe with skinny needle biopsies that don't perforate. I certainly would not want that to happen, but a way to get bites that are very deep in the wall of the esophagus, because I think that they'll be very telling. Final thoughts, there's more to the wall of the esophagus than just the epithelium and the lamina propria, which is what we get with endoscopic biopsies now. The bar here is demarcating the muscularis mucosa. Here's the submucosa, and here are the layers of the muscularis propria. We're seeing a very small, it's amazing that we've been able to come as far as we have, and we have come a long way with these biopsies and understanding eosinophilic esophagitis. But we completed a study of resected esophagi from children who had strictures that were fixed. They were not responding to dilation. They were causing dysphagia and so on. One of the children had eosinophilic esophagitis. Most of them had strictures because of ingestion of corrosive substances, unfortunately. The point I want to make here is that this is a periostin stain, which is known to be upregulated or deposited in increased quantities in strictures in other parts of the GI tract. There's no space between this fibromuscular tissue and the epithelium. There's no lamina propria, so you don't need a lamina propria to form a stricture. And here also is fibronectin. Fibronectin is deposited in abundance, as it is here in strictures in other parts of the GI tract. The epithelium here is separated from the underlying tissue, but there's no lamina propria here either. So we really need to get to the deeper layers of the esophagus to adequately work with suspected strictures and so on. So thank you very much for your attention. Again, thank you for the opportunity to be here, and I'll be happy to answer any questions.
Thank you, Dr. Collins, for your great presentation. I invite people to make questions also regarding this presentation. And in the meantime, I would like to ask you, is there any specific finding in your histology score that can be attributed only to EOE? And because, you know, I studied a little bit the histology score for gastroesophageal reflux disease together with my pathologist here in Italy. And most of the findings that you described are also present in gastroesophageal reflux disease. And so...
Unfortunately, there is not a way to look at a biopsy and say that this definitely is eosinophilic esophagitis, or this definitely is GERD, or this definitely can't be the two together, because they can coexist. Nor is it possible to look at a biopsy with a lot of intraepithelial eosinophils and say that this definitely is any one of the disorders that Dr. Schofer showed on his slide as being part of the differential diagnosis for EOE. We don't yet have anything that is pathognomonic. And I think things like abscesses and surface layering, they occur when there are a lot of eosinophils in general. So they are a marker more for there are a lot of eosinophils somewhere in the esophagus, rather than being markers of a particular disease that's causing the pathology in the esophagus. Some of the abnormalities persist longer after eosinophils have disappeared. Dilated intercellular spaces, I think, persist quite a bit. So I guess they do in GERD too.
Yes, unfortunately.
And surface epithelium as well seems to be a little more difficult to get rid of in some cases than in others. But perhaps, I don't know that even a special stain would be helpful in that regard.
Do you know how commonly is used the histology score in the United States? Because I believe that similar for the RFs for endoscopy in Europe, I believe that also the histology score is not really well or commonly used also in at our pathologist center here in Europe, at least. I don't know in the United States.
Right. I think that an impact is evaluating more features than there were evaluated before. But the formal grading and staging actually is more likely to be done in non-expert centers, not in centers that don't see a lot of EOE patients. Those are the pathologists who seem to be using it routinely. A few publications are suggesting that some of the larger centers are starting to use it. It's being used for a registry, for example, in Canada and Western Canada. But yeah, overall, I don't think it's been, and I encourage gastroenterologists, if they think it's useful, ask for it.
I think so, yeah. We have to ask it.
Yeah, I would like to follow up, Margaret, on this issue, because our pathologists, they are not excited when you ask them to use a score in clinical routine. How much time do they need more when they look at the slides to implement this score in their clinical routine practice? This is part number one. And question two, do you think that using the score in clinical routine, would it have impact on treatment decisions in certain situations?
Oh, absolutely.
In addition to the endoscopic manifestation, the symptom load, etc. So would it add on it?
I absolutely think the second question has an answer of yes, because it tells you which way you're going with the therapy. So if, it is therapy, it will tell you too, with a diet intervention, how things are going with the diet intervention, whether there is a reaction to a particular food that may not have triggered a big symptom response, but absolutely it, yes, influences treatment decisions. About how long it takes, everything has a learning curve. The easiest ones to evaluate, and you can make the scores the first look under the microscope, and you've got a really inflamed biopsy, you've got grade 3, just about everything, it's just obvious, or a totally normal biopsy, and everything is great in stage 0. Those two are very easy. The ones in between, you need to know how the features are defined. So there is a little time input there to remember or look at or make a little form for yourself that you've got next to your microscope. But once those things are in your mind, and it doesn't take much to get them there. Everybody knows about GERD. There isn't anything different here, really. Maybe surface layering is more common in here, but this isn't any new pathology. It's just a way of systematizing how you look at the pathology. So after an initial investment of not a lot of time, it becomes easy and not time consuming.
Let's start with that, and you will appreciate that. That's the meaning. And I have another question for you, Margaret, because sometimes it happens, my clinical practice at least, that I treat a patient with eosinophilic esophagitis with budesonide or steroids, and the eosinophils disappeared, but a lymphocytic esophagitis appear. Maybe this, and the patient become asymptomatic. So theoretically, I treated the right disease, and he's without symptom now. Which is the meaning of the lymphocytic esophagitis?
Yeah, I appreciated Professor Schofer's last few slides in his talk. I think that the jury is still out on the relationship between eosinophilic esophagitis and lymphocytic esophagitis, and sometimes they can coexist. There is a name given to the coexistence between the two, lots of eosinophils and lots of lymphocytes in the same biopsy at the same time. I'm not surprised that there could be a relationship, because T cells certainly are so involved in eosinophilic esophagitis that it wouldn't be surprising that there might be a situation in which they become more abundant after the eosinophils disappear. You would think they would be there. Maybe they are there and we're just not able to see them because of the abundance of eosinophils. They become a little harder to see, and the granules are all over the place and so on. I don't know exactly the relationship now, but I think it's something we need to pay attention to, publish about, and continue to study.
I think so, but my question is, I have to treat also lymphocytic esophagitis, and how I have to treat it? That's make everything a bit complicated.
It certainly does. One would think that swallowed corticosteroids would be an effective treatment, but you don't know exactly what you're treating, so that is kind of tricky. I agree.
And I don't know if there are more questions for Margaret, Stefan.
Oh, the Q&A is empty, and we have discussed a lot of things, so I think we should move on.
Thank you.
Wonderful. Thank you, Margaret. Thank you.
It's really a pleasure. We would like to move on now to the next presentation, and I'm delighted to introduce Arjan Bredenort from Netherlands. He's a consultant gastroenterologist at the Amsterdam University Medical Center, and his real clinical and scientific focus is the esophagus, not only eosinophilic esophagitis, but also achalasia and reflux disease. And he overviews a large population in the Netherlands with benign esophageal diseases. And finally, he was the last president of the European Society of Eosinophilic Esophagitis, the EUREOS, and he really moved on this society during his term, and it was a pleasure to work with him in this regard as well. So the focus of Arjan's presentation today is diagnostic techniques. Arjan, are you with us?
Yes, thank you so much, Stefan, for that introduction. Very kind. I will talk about, so we heard from the previous two speakers about the use of endoscopy and the histology, but I will explore with you whether there are other techniques that can basically replace endoscopy and biopsies. So we'll see about that. So here's my disclosure. So I will talk for alternative techniques for diagnosis and monitoring of EOE, and finally a bit about techniques for identification of culprit foods in EOE. And So the current situation, as we've heard, is that endoscopy with biopsy is used in clinical practice for both diagnosis and monitoring. But what we haven't heard is that it is expensive, it's uncomfortable, and it carries certain risks. So how do we use endoscopy and biopsies in EOE? Well, for diagnosis, basically one of the purposes is to identify EOE, but equally important is to exclude other disorders that may result in a similar clinical presentation. So let's think about the 60-year-old with dysphagia. He will not only need an endoscopy to diagnose EOE, but also there could be cancer. Or the young patients with chest pain that can also have reflux disease. So it's not just to confirm EOE, but also exclude other disorders. And for monitoring, we need to distinguish active from EOE from EOE in remission, but also the presence of fibrostenotic disease, as were elegantly shown with the EREF score. So in the agreed consensus guideline, it was discussed how to diagnose EOE. Well, the endoscopy with biopsy is central here, but also the long list of disorders that need to be eliminated or excluded before we can say it is really EOE. So are there any alternatives? Well, Ulrike von Arnhem explored the clinical prediction of EOE and basically to replace endoscopy in certain situations, to find a combination of clinical and lab biomarkers that can predict EOE. It's a small set of patients with EOE and GERD, and they can be reasonably distinguished based on the presence of atopy, refractory PPI symptoms, history of food infections, peripheral eosinophilia, and IgE elevation. But of course, this needs validation in a much larger cohort, and not only with GERDs as controls, but basically everything you can find as a control. So also cancer patients and patients that do not have any abnormality. And the sample size is much too small for any regression analysis, of course. Here's some work from Evan Dallin, where he also combined clinical endoscopic features and then used biopsies as gold standard. And you can see that this results in a fairly good area under the curve of 9.4. But the question is, of course, could this avoid the effort and expense of the histological examinations in patients where you already have a very high suspicion of EOE? And we've heard about the EOE-like disease with no eosinophils. So I think that will be difficult to distinguish. And so also a disease like Lichen could very resemble EOE endoscopically. And the experts evaluated endoscopy. We don't know how this will go when there's non-experts doing the EREFS evaluation. There's a selection of cases, obviously, and also not validated in an external data set. Also some work with serum markers in children here, EOE. Also looking at some other biomarkers, and well, they found differences between boys and girls. But well, this was not found in controls, but no diagnostic values on these parameters. And there's even a urine biomarker test with urinary 3-bromotyrosine that is much higher in EOE patients than in non-atopic controls and atopic controls. But 3-bromotyrosine is a product of eosinophilic induced damage. The authors conclude that this urinary 3-BT can potentially serve as a non-invasive marker of EOE, but I doubt it, because it can also be increased in other conditions where there is eosinophil induced tissue damage. So maybe more as a monitoring tool. So for diagnosis, I don't think the current research allows us to pick another tool than the endoscopy and the biopsies. And so indeed, Alain told us take 6 biopsies and evaluate the pathology. So the question is then, how to monitor. And before I go deeper into that, the reason is also why to monitor. And just a few slides why we should monitor EOE. And this is from the work from Alex Straumann. And here he looked at the natural history of EOE patients in his cohort. At the time, there were no treatments available at all. So he it had a very excellent possibility to study the natural history. And he found that those with a short history had relatively little endoscopic abnormalities. For example, the left upper corner, panel A. Well, if you look at panel D, this is a patient with a very long standing history of EOE, and there are severe endoscopic abnormalities. And what he found was, with this long-term follow-up of untreated EOE patients, that they all will have continuous dysphagia, continuous eosinophilic infiltration, an increase of fibrosis in lamina propria, no malignancy. So it's a chronic disease, and it leads to persistent dysphagia and fibrosis at the long end. There's more data here from Alain Schupfer that delay in diagnosis, so basically an untreated disease increases the risk for stricture formation. So we really want to know if there's histologic remission, otherwise patients will have accumulating risk for stricture formation. And here's data from our own group, where we reviewed the files of a very large population of Dutch EOE patients and looked at endoscopic abnormalities in function of the duration of the diagnostic delay. And that's on the horizontal axis, the diagnostic delay. And what you can see is that the longer the diagnostic delay, the more often patients will have fibrotic endoscopic signs. That's what you can see on the left. On the right, you can see is that the longer they have an untreated disease, they have treatment delay, the more often there's an increase in strictures and food impaction. So long-standing untreated disease leads to fibrosis, strictures, and food infections. So why should we monitor EOE? To prevent persistent inflammation that would lead to fibrostenotic complications. So it is certainly important to monitor. So why should we do this with biopsies? Can't we just go for clinical response? Would that not be enough? Well, this is also data from Dr. Schupfer, where he looked whether symptoms as measured with the validated PRO instrument could predict histologic remission. And you can see here that in the receiver operating characteristic curve, the performance is really poor. So basically, symptoms not sufficient to predict histologic activity. Now, if we look again at the endoscopic signs of EOE, there's the edema rings, exudates, furrows, and strictures. Here are the fibrotic signs, and here are the inflammatory signs. So endoscopy can help you to monitor these. If there's an increase in fibrotic signs, it goes in the wrong direction. Can we use endoscopy alone to assess disease activity? Can we use endoscopy to predict the histological activity? This is the data from our own group. And basically, well, there is more endoscopic features related to higher eosinophil count. There's no or very low predictive value. So endoscopy alone cannot be used to assess disease activity. So we really need those biopsies. Now, how you ideally want to monitor EOE? So you ideally want a tool that's inexpensive, non-invasive, and accurate. And endoscopy with biopsies is just not inexpensive and non-invasive. So which alternatives have been explored? And there's a long list here. Biomarkers, manometry, impedance techniques, endoflip, cytosponge, and the string test. And I will go through them one by one. So serum biomarkers, so a combination of a biomarker set that could work, but unfortunately in this explorative study, there was no difference between EOE and controls, and also no difference in EOE pre and post treatment, so not suitable. This is more work, quite similar, where they looked at serum markers in response to a data set of a trial of budesonide versus placebo. And they actually found that certain serum markers had a response which they didn't find with placebo. So that may be worthwhile for further exploration. Esophageal manometry. Several studies being published. I've selected this one because it's the largest group and very clear. So in patients with EOE on high resolution manometry, you'll find often normal peristalsis or weak peristalsis or absent peristalsis. And the abnormalities are variable and there's no distinctive pattern. And so basically that also means that you cannot use it to either diagnose disease and you can also not use it to monitor the disease. So this option is also off the table. What about the impedance techniques? There are several different techniques being explored. This is the 24-hour the baseline impedance monitoring in a 24-hour impedance study. It's quite a simple technique using existing technology. It found that there are some differences between EOE and other patients. The baseline impedance is much lower in EOE, in the proximal, but also the mid and distal esophagus, because the cause is different, not acid, as it is in GERD. And there's a gradient. There's also the mucosal impedance technique. This is developed by the group of Michael Vasey. It's a through-the-scope impedance device that you can press on the mucosa and it will give you a signal. And here you can see that EOE has a distinct signature from reflux disease and achalasia. So that suggests that it might work for diagnosis, although of course the group should be much larger and also exclude other patients. But maybe this is potentially worthwhile. And here's another technique that we've worked with in Amsterdam. It's the electrical tissue impedance spectroscopy, a through the scope impedance device. It's well validated against electron microscopy and Ussing chamber permeability experiments, where we have tested it for against other techniques that tell you something about mucosal integrity. And there is a correlation with for the impedance and the number of eosinophils per high power field, and you can see that the data points are quite scattered, and that also results in this mediocre ROC curve with a diagnostic accuracy of 78%. So probably the diagnostic role will be limited, and if it has any role, the impedance, it will maybe for monitoring disease activity. Then the EndoFlip. This is for those of you that are not familiar with EndoFlip. It's a compliant cylindrical bag filled with saline. You place it in the esophagus and then you perform a stepwise distension until there's no further increase in cross-sectional area despite an increase in bag pressure. And if you look at it in a control subject, if you apply more pressure, you'll have an increasing diameter that reflects the elasticity of the esophageal wall. But in a patient with EOE and a narrow esophagus, you'll see that more pressure will not result in increased cross-sectional area. So this could work to identify fibrosis. And it seems that this also able to measure treatment response. On the left, you see an EOE patient treated successfully with topical corticosteroids, and you see that the curve is similar to the diagonal line that I showed you in a healthy subject. So with increasing pressure, there's increasing diameter. While in an EOE patient treated unsuccessfully with a diet, the line is not going diagonal, more of a flat line. So the improvement in this disability with diet and drugs without dilation can be measured, and this data suggests FLIP can be used for monitoring EOE. Cytosponge, I personally think this is really an exciting technology. It's a spherical sponge contained in a dissolvable capsule. It's originally developed for screening of Barrett's esophagus. So patients swallow it with a bit of water. String is held outside the mouth. After 5 minutes, the string is pulled and removed together with the sponge, and that now contains cells that can be evaluated. And here's a small feasibility study where 83% of the individuals with active VUE were correctly identified, no complications, and the patients preferred the cytosponge to endoscopy. So this could be really something in the future. And there's also a special safety study being done, and that shows that there's no adverse events, no sponge detachments, and there's no issue with sponge passage or retention. The only thing is, of course, that if patients cannot swallow the sponge capsule due to a stricture, that technique cannot be used. So I truly think this is a promising tool for monitoring EUE. What looks a bit like it is the string test. This is basically just a string that is swallowed in the evening, one end taped to the chin and removed the next morning. And then all mucosal cytokines are attached to the string the next morning. And then you can perform analysis on the cytokines in the strings. For example, MBP can be measured, and that correlates to peak eosinophils. So this can also be something to use to monitor the disease. And it's an indirect way basically to assess the mucosal inflammation. So if we look at these new tests to assess disease activity, I think it is certainly possible that for monitoring EUE, we could use different techniques in the future. So maybe particularly cytosponge and string test could work here. Well, a few words then about the problems with identifying the culprit foods, because this is really a huge problem in EUE. So among patients, diets are very popular, and they'd rather avoid the 2 or 3 allergens that induce their disease than commit to any long-standing medicine. That's often the case. But the problem is you don't know which allergen is causing the disease in an individual patient. So you could use, you could go for the 6-food elimination diet, the very extensive diet, milk, soya, wheat, egg, peanuts, shellfish. But adherence is a problem, very broad exclusion. And what we then do is we stepwise reintroduce each food group and then perform endoscopy to check if there's still inflammation. But you cannot use the symptoms for the exclusion steps. So you need a lot of endoscopies for each food group. So preferably you make a diet based on the results of allergy testing, and then the patient just eliminates 2 or 3 allergens and is healed from the disease. Well, in allergology, commonly used is skin prick test, serum IgE, ATP patch test, but I'll show you that the results are not so fantastic. Here's some data where they use the skin prick test and the ATP patch test to 26 foods in a group of adults with EUE. And then in 15, there was an elimination test done, and only 1 out of 3 that worked. So it doesn't predict causative allergens that well. Here's another study from Australia where patients underwent 5 allergy tests and then subsequently had a 6-food elimination diet with stepwise reintroduction to identify the food trigger. Well, here's some of the results. The ATP patch test was always negative for the foods. The serum IgG identified 13 foods correctly, missed 11, and wrongly identified 19. And serum IgE and skin prick test identified foods, but not the correct one. And the basophil activation test was negative to all foods. So this is certainly not excellent, and no allergy test accurately predicted the causative foods. So that doesn't work. And finally, here a study from Alfredo Lucendo, where he used skin prick tests and serum IgE tests and then link that to the results of the 6-food elimination diet with the stepwise reintroduction. And well, the sensitivity varied between 0 and 50% and specificity between 50 and 90. So again, there's hardly any concordance with the food reintroduction challenge results. And so this far, we're still stuck with endoscopy and biopsies. At the moment, we are developing the following. This is still an experimental technique where we inject food allergens in the esophagus to see what happens, because our hypothesis is that these skin prick test and serum IgE tests don't work, because in EOE, the sensitization is limited to the esophagus. So maybe you can trigger this by injecting allergens. So what we did is we injected the 3 most common allergens in the esophagus of patients with EOE, 3 based on the personal history of the patients and controls. And we used the sclerotherapy needle to perform this. And here's an example. You see on the left, you can see the esophagus before injection. Then there's the injection of the allergen. And then sometimes within like a minute, there's a blanching of the mucosa, swelling, and a very tight stricture occurring under endoscopic view. And here's another example where you can see it on the left, the esophagus before injection, and in the middle and on the right, what happens after injection of the allergen. So this is certainly not something for clinical care, but it could lead us maybe to an alternative way of identifying food allergens, and hope to tell you more in the future. And I now come to the conclusion of my presentation on advanced diagnostic techniques in EOE. For the next certainly 5 years, endoscopy with biopsies will remain crucial for diagnosis of EOE. It's the only tool to exclude disorders with overlapping clinical presentation. The cytosponge and string test hold promise as tools to monitor inflammation. EndoFlip may be used to monitor fibrostenosis. And I hope to bring you more about techniques for identification of culprit foods in the future. Of this, really like to thank you for listening, and happy to answer any questions. Thank you.
Thank you, Arjan, for this excellent comprehensive overview over these many techniques that has been explored in the EOE, and you have really sorted out what is presumably off the table and what may still have some promise for the future. I do see 2 questions in the Q&A, and I will forward this question to you. Can we grade histological response to treatment, and how to define a remission histologically?
Yeah, so I think the grading of histological response with EOE HSS, that's really something for Margaret to respond to. In how to define response based on eosinophil count, that would be, well, there's a simple answer and there's a more complex answer. We always used to define remission as less than 15 eosinophils per high power field, but and that's also what we defined in the Corios exercise. But the FDA actually demands a cutoff of 6 or less. So
yes, because I have also trouble with this issue, because in my understanding, the cutoff of 15 was always a diagnostic cutoff, which is important to make the diagnosis of EOE after ruling out other causes. But remission of EOE, because what is about a patient who, when you diagnose with a new diagnosis, he has, let's say, 20 EOs per high power field, and you treat this patient, and on follow-up, he has 13 EOs. Is this, would you regard this as histological remission? He is clearly below the cutoff. We know that it's a patchy disease. You can have sampling errors. Yeah. And if you ask the pathologist, the normal state of the esophagus is 0 EOs. Usually there are no EOs in the esophagus. So this raises for me the question if this cutoff of less than 15 is still valid. Because for me, it's more a diagnostic cutoff, but not a cutoff to define histological remission.
Yeah, so sometimes if your patient comes from 100 eosinophils and then has 20 after treatment, I wouldn't be too strict, and I think you're doing it successfully, particularly if the symptoms are have improved considerably. We don't really know if when you will develop fibrosis. So probably if you have no eosinophils left, the fibrosis formation stops, but we don't know if it still continues at 10 or 20, or whether it is twice as fast if it goes at 40 or 80. That's still things to explore.
Yeah, okay. Here's one question regarding EndoFlip. Do you use EndoFlip in your EOE routine clinical practice? Will it play a role in this setting and give additional information as compared to endoscopy alone?
Yes, it does give additional information, but I don't use it in clinical practice. For now, I think that the information I get on fibrosis on using the EREFs and the histology evaluation is sufficient. And EndoFlip is another invasive test, and it's also costly.
I have a follow-up question on this. Sometimes I do see patients who come back on follow-up after treatment or after steroid treatment. Histology is fine, endoscopy looks good, but sometimes they say they still have dysphagia, residual dysphagia or remaining dysphagia, not as much as at the beginning, but they are not symptom-free. What would you recommend in such a situation? Taking deeper biopsies or implement manometry to see if they have residual motility disorders, or what would you do in such a situation?
Yeah, so it can be that there's a stricture that's causing the ongoing.
That's ruled out by endoscopy. So the
okay.
Endoscopy looks fine.
In that case, it can be a sampling error. But if that's unlikely and you're convinced that it is the EOE is in remission, it can of course be a functional symptom. And there's also a study that's showing that patients with EOE have esophageal hypersensitivity. Yeah, right. So that's certainly possible.
I do see one question in the Q&A which refers to your presentation. Is EOE immediate or delayed hypersensitivity to tell about RAS test versus patch test?
We don't know.
We don't know, right?
Well, it might have something of both. Some patients report immediate symptoms, and sometimes when we injected the allergens, they said, well, they reported their pains or their burning sensations that they recall from food impaction episodes. But it's also a more chronic disease that has features of a more delayed hypersensitivity. Probably it will not be classified exactly in one of the traditional hypersensitivity classes.
Okay, thank you. I do not see any more questions in the Q&A regarding your presentation. So thank you very much, Ariane, again, for this excellent talk. And we move on with the program. We have a little change. We go now directly to the presentation to Evan Dellen and the picture gallery, and continuing discussion. If there are more questions, we will have at the end of our symposium. So with that, now it's my great pleasure to welcome and introduce Evan Dellen. He is professor for medicine at the North Carolina School of Medicine in Chapel Hill. He is the director of CDAS, which is the Center of Esophageal Disease and Swallowing, since 2014. And I think when it comes to EOE, we don't have to introduce him really, because he is a worldwide known expert on EOE. He has published around 300 papers or co-authored them on EOE. So if you have any question on EOE, or at least I always contact him, because he can answer everything and has researched and studied everything on EOE. So it's my really great pleasure to have him with us. I look very forward to his presentation, and his title is Endoscopic Management of Complications in EOE. Evan, please.
All right, terrific. Thank you so much. I'm going to go ahead and share my screen here. And can you all see that all right? Yes. Okay.
Yes.
Terrific.
Yes.
Well, thanks again, and it's really wonderful to see all of the interest here, and I'm looking forward to going through this topic on the endoscopic complications of EOE, and I've interpreted. Well, let me start here. I have some disclosures here related to EOE and other eosinophilic GI diseases. And what I'd like to do is I sort of interpreted complications in a little bit of a broad perspective for this talk. And for this talk, what I'd like to do is first emphasize the role of a good endoscopic exam as a starting point for assessing and preventing complications. I don't want to overlap too much on Dr. Schopfer's presentation, but I think I have a different perspective on some of the information that he's going to tell you with some very practical points also. And then we'll go through the main complications in EOE: food impaction, strictures and dilation and perforation. And then towards the end, I want to emphasize also that most of the complications in EOE are due to esophageal remodeling and fibrostenosis, which are probably more common than we think. And for the treatment algorithms that we're going to discuss, I'd like to propose that we have an arm for treating inflammatory component of EOE, but also for fibrosis. And I'll show you what I mean by that towards the end. So for optimizing the exam, I want to harp on this a little bit because I see a lot of referrals, and even among my colleagues, where a good esophageal exam isn't done. And this is really critical in EOE. You need to take your time, fully insufflate the esophagus, gently wash off a little bit of debris to really assess things. I look actually on an insertion before I do the whole exam and going down to the duodenum, because sometimes if the scope is in and going back and forth, you can actually wipe away a lot of the exudates, and you may underestimate the extent of inflammation. And while I'm doing that, I'm looking very carefully. I'm being aware of subtle findings, strictures and narrowing. And I'm going to show you examples in the middle of the talk where strictures can hide at the GE junction, upper esophageal sphincter, and how narrowing can hide as well. The other thing is, if you encounter a very narrow ringed esophagus, grade 3 rings, don't push against resistance. I'll show you an example of this. And of course, as Dr. Schopfer talked about, document the EREFs thoroughly. So these are real world examples of patients that came to my clinic with suboptimal endoscopic views in the first 5 panels. And so, you can see here a poorly insufflated esophagus, unwashed. Here, even though most of the debris is washed off, it's poorly insufflated. You can't tell if these are actual rings or if that's a furrow or whether this is actually edema or not until you fully insufflate. When blood covers stuff, you can't see. 2 examples here of poor washing where you really, can't have any appreciation of the finding. And so this is the kind of view here in panel F that I think we want to aspire towards. Clean, fully insufflated, no question, that you can see, at least grade 2 rings here, furrows and edema, and very subtle areas of exudate here that you don't want to miss. Here's another example of, even though an esophagus is nicely washed off here, this is under-insufflated. And when you insufflate it more, you can see that there's actually a stricture here that's difficult to appreciate in this picture. And in fact, this is a 12 millimeter stricture. This is the result of dilation with a 14 millimeter bougie. And you wouldn't necessarily assume it was quite that narrow just based on this appearance. Now, these are 2 examples of actually 3 examples of actual endoscopic reports that I got. And I just say here, there's no evidence of esophagitis, no evidence of furrows, rings, or other signs of eosinophilic esophagitis. Clearly, there are signs of eosinophilic esophagitis here, but when it's not insufflated and when there's all this saliva, you just can't see anything. Here, middle third of the esophagus, normal, not normal, right? Even up here where you don't have any edema, you can still see furrows and perhaps a little bit of exudate. And so be careful of how you're documenting and what you're writing. And even here, the report said rings and furrows in the middle and lower esophagus. And you can see rings and you can see furrows here. But what did they not mention? They didn't talk about the edema, and they didn't talk about the exudate, and they didn't talk about the stricture right here. And so again, these are real reports that I've seen in my clinic from being referred over. And so I don't mean to harp on it too much, but be sure to do a nice exam. And then with that, don't push it. This is an example of a patient. You put the endoscope in at around 20 centimeters. This is what you encounter: a very, very narrow esophagus, ringed, edematous, exudates. And if you push the scope forward, you may not see this until you come back out. And this is, injury to the esophagus from the scope. Now, if this was a dilator, you would say, oh, that's what I want to do. But is this crepe paper mucosa? Is this a dilation effect? Or is this a complication? You don't want the scope to be doing this necessarily. You want to appreciate that you can't push the scope through here, switch to a smaller scope, and then this careful exam will help you prevent, luckily this person didn't have a perforation, but it can help you prevent this kind of situation. Okay, so it may be dinner time or close to dinner time in Europe. It's after lunchtime here in the US. And so it's a good time to talk about food impactions. We're always getting called in at nighttime for this. A clear example here in EOE. And the question is, how can you most safely remove this bolus and examine the underlying esophageal findings and make the diagnosis? So what do we know about food impactions? What's been going on? Well, this is a long known relationship between EOE and food impactions. Some early papers here, both in children and in adults, looked at the food population, and more than 50% of patients, even at that time, who were presenting to the emergency room, had food impactions. So this is a high prevalence population. If you're seeing someone with food impaction, most likely it's going to be EOE at this point. And you can look in this paper, even though it was an older one, you can see over time the increasing number of food impactions. And in this graph, a good chunk of that increase is made up with EOE patients. Now, what's interesting you can see is there's a proportion of patients here where biopsies are not done. And that's a group where we could be missing EOE. And that's another, I think, important thing about preventing complications of EOE. Now, this is a systematic review and meta-analysis by Girish Hiremath, who's a pediatric GI in the US here in Tennessee at Vanderbilt. And he did some pooled analyses. And he looked at, first of all, for patients undergoing endoscopy for a food bolus impaction, what's the proportion with EOE? And in all of these studies, the pooled value comes out at about 54%, so similar even to those early studies. And he also looked at what the biopsy rate is in all patients having a food impaction. And unfortunately, it was also only 54%. So about half of patients are not getting biopsies, and you would think that there's at least in that group about half who we are missing EOE if we don't get biopsies. Now, I want to also point out that the emergency endoscopies for food impaction in this population is a potential time for complications. This is a paper from the Swiss group, and they looked at 87 patients responsible for 134 food impactions and found 2 perforations. Now, both of these perforations happened trying to clear out the food, but they were with rigid endoscopes. And I think this is one reason that we're rarely using, if ever now, rigid endoscopes to try to clear out food impactions. And one patient had a complication of Boerhaave syndrome, so esophageal rupture, due to the food impaction prior to having the endoscopy. There have also been reports of patients who have had the tools that you are using to remove the food impaction perforate the esophagus themselves. And so this is a time to be especially wary when you're going to remove the foods. Now, in terms of what to do with food impactions, I think there's still a lot of variability among providers. And this is a very nice collaboration led by Philip Schreiner, a collaboration both of European and US EOE researchers, surveyed 308 endoscopies, most actually in Europe, most treating adults, and asked about their practices for treating food impactions. And there were some things that they agreed on, such as trying not to induce vomiting, that medications to clear the esophagus like glucagon or nitrates typically are not effective, and agreement on doing the endoscopy relatively urgency, mostly within 6 hours. However, there is less agreement on doing biopsies and certainly on doing dilation at the time of the impaction. And there was a lot of variability with anesthesia choices and how to clear the impactions. So this is a graph showing the different choices of anesthesia that are listed here like monitored anesthesia care, conscious sedation without an anesthesiologist, conscious of 2 different types, no sedation in adult gastroenterologists, pediatric gastroenterologists. So there's lots of colors here, lots of variation. And then when you ask everybody, how do they get the food out? It's really all over the map. And so, with lots of different techniques used, maybe the nets are the most common, followed by different forceps or snares, the cap used a little bit. And then what about the push technique? Some people say never, Some people say sometimes, some people say they always try that. And so I think that this is an area where we need a much more standardization of care, but there's also, of course, a lot of variability on the patients that you're taking care of. So you have to make some decisions during the procedure. So what about this push technique? What that refers to is trying to use the scope to push the food into the stomach. There are reports that this can be done safely, both in children and in adults. But in EOE, I think you want to be very careful about this. And I'm doing this technique less and less because it's really a question of what's lying below that food impaction. Now, if there's food and it's kind of floating up in the top, more proximal esophagus, and you can direct the camera around there and see, and then go into the stomach, that's one thing. But if there's, a good hunk of food that's impacted in the distal esophagus, there's a good chance there's a stricture there, and it could be tight, and the push could lead you into trouble. So you've got to use some judgment and some caution. I find that the cap and suction technique can be very helpful if you have the right cap. Some of the caps we have are short and small, and there's not enough space here to create suction between the scope and the cap and the food bolus. But if you use a longer cap, particularly, for example, the kind in a single bander device, that has a nice long area that you can create suction, get the food up in there, and then pull it out in one piece in the esophagus. And these are just some examples of different kind of caps, especially these two for mucosectomies or EMRs that could be very helpful. I think the graspers, they work, and so do nets and snares, but you get into this thing where you're picking at the food forever, and it seems sometimes to be not efficient. Now, the last thing I would say is take biopsies when you're done clearing out the food. I know no one at 3 in the morning wants to take extra time to do this. I don't either, but it's an important period of time, and I'll show you why, because you may miss a lot of patients. But when you're doing this, go where the money is. There's a paper here that this sub-EUS area, the first inch or two or first several centimeters of the esophagus, is very rarely involved with EOE. And this is a good example in one of my patients, normal mucosa here going down to abnormal mucosa in EOE. Biopsy where it's abnormal. Use the turn and suck technique. That I'm sure you've heard about already, where you get a nice piece and leave a good area targeting furrows and exudates as your highest yield. And do this in an area that's potentially outside of where the food was stuck. Of course, if food is stuck there, you'll have a lot of local inflammation and irritation. So you can get biopsies from down there, but get them in a separate jar removed from where the food impaction is. I wanted to mention that one of the patient groups based in the UK EOS network has a very nice patient action plan for what to do with food impaction. And you can go to this website and check that out to give to your patients. And then why is it important to get these biopsies and to follow up these patients after food impaction? This is some data from Joy Chang at the University of Michigan, where she looked at patients with food impaction, and more than half did not have follow-up after the food impaction. They never came back. And in fact, she found that EOE patients were more likely to be lost to follow-up. And so this food impaction may be a critical time where we can intervene, get these patients into our systems, and prevent future complications, which I'll talk about in a minute in this group. And that would be a good way to do this. So this other data from UNC also shows that even after initial diagnosis, a quarter of patients don't come back. So it is a population that's at high risk for not following up, at least in the US. All right, let's turn our attention now to strictures and EOE. Here's an example of a very tight stricture. And I'm not going to spend as much time on the progression here because you heard a little bit about it in the last talk. Dr. Mielke will talk about it a little bit, but we have this conception that EOE in many, but not all people, progresses from an inflammation predominant, kind of picture to one that ends up having superimposed fibrosis. And we see this with longer duration of disease in adults, and it may impact our treatment, medical therapy for inflammation, dilation for fibrosis. And these are some data you just saw in Dr. Brinor's presentation, but 4 different studies from 4 locations in the world. The longer you have symptoms of EOE prior to diagnosis, the more likely you are to have strictures. And by the time you're up to 20 years of symptoms, you're up to 60–80% strictures or more. Now, this is an example, an actual example of one of my patients, 36-year-old, long-standing history of trouble swallowing. This was him in 2008. Yes, there was some narrowing and fibrosis here, but he was out of care for 7 years and came back. And this is how narrow his esophagus was. And to give you some perspective, this is the tip of a spring tip guide wire. So this is 2 millimeters. So you can see it's only about 6 millimeters that he's progressed to there. He's really narrowed down over this time. And that's what we're talking about and want to prevent with some of this, this talk of progression. Now, we even had a recent study where we looked with patients who progressed even after diagnosis. And these patients who didn't come back for at least 2 years, had a diagnosis, were on treatment, but were just out of care. And we looked at the patients before and after they had this gap in their care. And what we could see is when they returned, they had higher endoscopic severity and worse strictures. So for example, their stricture diameter went from 13 to 11 millimeters. Their endoscopic severity scores went up. You can see the proportion of strictures going up here, 19 to 36%, narrowing 9% to 21. And so this happens, this progression can happen when people are already in care. And you can see that with the longer amount of time that they were out of care after diagnosis, the higher proportion of strictures. So again, some corroborating results for progression, even among patients who theoretically were under care. Okay. Now, what do we know about the strictures? Where are they located in the esophagus? This is a study of nearly 800 patients from our database here. About a third, just over a quarter, had a stricture, and we could figure out where it was. And so you see here, the most common location is distal. Mid is relatively uncommon, then proximal, and then diffuse narrowing. And we didn't find too many predictors of location of strictures. The mid-esophagus patients tended to be younger, and women tended to have the more diffuse narrowing. But you could expect in the EOE patients to find strictures really in any location of the esophagus. And I think it's one of the real questions of the disease is why these strictures form in different esophageal locations. Now, this was a recent and interesting study out of the ESPGHAN EGID working group, where they identified a group of children with strictures. Now, children generally are felt not to have as many strictures as adults and to be less severe. And the question is, to what extent are these strictures fibrotic as opposed to inflammatory? So in these children, they had some pretty impressive strictures. 16 were less than 9 millimeters and 20 were less than, oh, I'm sorry, and 4, that's a typo, 4 were less than 6 millimeters. They were treated with oral systemic steroids for 4 weeks, and then they were transitioned to other treatments. And when they came back for their endoscopy, nearly all of them had stricture resolution. And dilation was required only in a minority. And so this raises the question about the timing of dilation, which we might talk about during our panel discussion a little bit, and whether you do dilation before or after treatment. So that's a good segue into esophageal dilation for EOE. And this is an example of what dilation looks like with the balloon dilator. You can see a very narrow caliber esophagus, a deflated balloon put out. The balloon is unfurled and expanded. And here you can see the result of the dilation. I like to call this dilation effect. I don't call this a tear or a rent or a complication, actually. I think this is the intended effect that we're looking for after a dilation. And were you to leave the balloon up and then have this view again, you haven't done a stretch and you need to expand the balloon a little bit more. You can do this safely with balloons or with bougies. Here's a very tight stricture, and you can see the rings, wire is down, and then the expected dilation effect and increase in esophageal caliber. So in early years of EOE, 20 years ago now, dilation looked very scary. There were multiple reports where you were having perforations, rates of tears, Boerhaave's, hospitalizations, and initial recommendations were really not to do it or to be very, very cautious when you were approaching this. But over time, of course, more and more data have been accumulated related to dilations. And this is a meta-analysis from a few years ago of more than 2,000 dilations on almost 1,000 patients. And the perforation rate was very, very low. And on the meta-analysis, it was really a negligible rate. And interestingly, only 4 perforations had occurred since 2009. And this suggests that as people were learning more about EOE and were learning how to approach dilation, it could be done very safely. And with this, the European guidelines from the United European Gastroenterology Journal recommended endoscopic dilation to improve dysphagia in EOE patients with a reduced esophageal caliber. with the caveat that I'll also mention that it doesn't impact the underlying inflammation. And that endoscopic dilation is a safe procedure with a risk of perforation smaller than 1%. And then this was emphasized just a couple of years ago in the American Gastroenterological Association and Joint Task Force on Allergy guidelines, where in adult patients with dysphagia from a stricture, endoscopic dilation is recommended. And again, they find very safe results in their meta-analysis for this guideline. The risk of complication for EOE now seem to be about the same as doing a dilation in anybody. But I would have a caveat with that there is a practical approach that you need to use. You need to be cautious with it. And I like this terminology, which is start low and go slow. And the way that I usually approach this is discuss what to expect with the patient, and that they need to expect to have some discomfort after the procedure. The large majority of patients are going to be uncomfortable and have pain. When you're doing the endoscopy, the most critical part of dilation is actually assessing the esophageal size. I think we often miss strictures, and I'll show you some data on that. So often you can start with an underestimate of the dilator size, sort of based on how it feels with the scope passing. Balloons or bougies are safe. I relook after the balloon inflations or after a bougie pass for dilation effect. And then, multiple sessions are usually needed to get to a goal of 16 to 18 millimeters. So in my practice, I incorporate these dilations into the endoscopies for monitoring endoscopic and histologic response. So the key point here with dilation, though, also is that is from this paper with Dr. Schopfer, that eosinophil peak infiltration, load, eosinophilic EOE-associated histologic signs were not affected by dilation. Dilation does not impact the inflammatory condition of the esophagus. So in my mind, it's one aspect of treatment, but not the only one. And also note, once the dilation is performed, it's really hard to interpret patients' symptoms. They may feel well because they have no obstruction anymore when they swallow, but they may have still a lot of inflammatory disease activity there. So if you're not sure about how to measure the esophagus, you can use sort of a balloon sizing approach where, here's a patient who's actually on therapy and there's just some residual rings and stricturing here proximally. You can put up a balloon and pull it back through the esophagus at a given size. This is 12 millimeters. It comes through without any problem. Then you go back and put it down. Here it is at 13.5 millimeters. It hangs up on this area, and then you know exactly the size to dilate. There's a newer technique, the cap-assisted technique, also just reported out of the Swiss group, where you have these different size caps that go on the tip of the scope, and they convert the scope itself into a dilator, and so you can kind of watch what you're doing. So here is how the stricture looks on the endoscope through the cap. Here is the dilation happening with the cap, making a dilation effect there, and here's post-dilation. And so this series of 50 patients showed proof of principle. It worked. You have to make sure the cap is tightly affixed to the scope. They had one patient where the cap came off in the hypopharynx and they had to get it out. But generally, this seemed to work quite well in EOE too. Now, when we're thinking about, again, approaching this from a practical standpoint, I think we have to admit as endoscopists, we're not good at picking up strictures. And this is data from the Mayo Clinic in adults, where they looked at barium esophagograms and endoscopy, and they found the sensitivity of endoscopy for detecting a decreased esophageal diameter using the radiology was poor. So in other words, only 33% of endoscopists picked up a stricture 13 millimeters or less. That's pretty bad. And if it's 15 millimeters or less, it was only a quarter of patients. And this happens in kids too. Very similar study. 55% of children with strictures were missed by endoscopy when they were found on esophagram. So I think this means we have to have a high suspicion for strictures in EOE. And this happens to me all the time. This is similar to the first patient picture I showed you. This patient was referred to me. It was a good endoscopic exam. EREFS was done, but they specifically said there was no stricture. And I pulled up the images. And again, here's a clear stricture at the GE junction or distal esophagus. This is not a Schatzki's ring, right? Here's the Z line. There's no hernia here. This is a stricture in the distal esophagus from EOE. And it happens to me too. I had my own patient. She had a very severe GE junction stricture. I was dilating it. It was improving endoscopically, but she kept telling me she had symptoms. And so and had food sticking in the upper chest. And so I did a bougie dilation, and proximally, this is what I saw post-dilation, a big dilation effect here. And I looked back at the picture before dilation, and this is how it looked, pretty good. Maybe a little hint of a furrow, slight maybe ring if you squint. But, you would never say that this was a 14 millimeter dilator. You would never say that that was 11 or 12 or 13 millimeters. So again, you got to listen to the patient and have a high degree of suspicion. And this is why I look before and after each pass. This is a balloon after 13.5 millimeters. And here's the dilation effect after 15. Here's a pass after 12.8 millimeters with a savory, and here's the pass after 14. So even little changes in diameter can lead to big dilation effects. And these are examples of what you're looking for as a goal in terms of your stretch. What about timing of dilation? Should it be before or after anti-inflammatory treatment? This is a study out of Northwestern where they did the endoflip technique and did not treat patients with dilation. And they gave either steroids or diet or PPI. And what you can see here, this is before treatment, a plateau that's around 11 or 12 millimeters of diameter. And after treatment, they gained about 3 to 4 millimeters. Of esophageal diameter, just like from the anti-inflammatory effect. So this is somewhat analogous to that systemic steroid given to the kids. So you can have some increased diameter after anti-inflammatory treatment, but sometimes this happens. This is a patient of mine, dysphagia. This is prior to treatment, 70 EOs, narrow ringed esophagus, strictured proximally, and then gave him an anti-inflammatory treatment. And he told me, I still can't swallow. The treatment didn't work. But look endoscopically, it worked. There's no edema. You can see all the vessels. There's no eosinophils. What's left is a bad stricture here. And so this is someone who needed dilation with the anti-inflammatory treatment. So it didn't open up for this particular guy. What else can you do with dilation? Well, I have a cohort of patients here who are refractory to treatment, and we just dilated these patients for their sole treatment while they were waiting for other therapies to come online. And they started with an average diameter of about 10 millimeters. We followed them for more than 1,000 days on average, and they got up to about 16 millimeters. And this approach let them be asymptomatic and wait for new treatments, and many of these participated in a clinical trial. The other thing, and this goes sort of the histologic response discussion that was just happening, that if you can get histologic response, you need less esophageal dilation afterwards. And these are patients from 2 different studies, both UNC and Mayo Clinic. They went into remission, and you can see for the people who are in remission here, they need less dilation going forward than the people who did not have histologic remission. Here, the patients who maintained on therapy needed less dilation than those not on any therapy. So again, an argument to do both. Okay, so for the last part of this, in the last few minutes, I just want to talk a little bit briefly about sort of the most dreaded complication is esophageal perforation. This was a patient who got transferred up to our center with this perforation. This is not usually an endoscopic view you want to see, but they did an endoscopy on him without doing an x-ray. This is actually the esophageal lumen up here, and this unfortunately is a giant hole leading into the mediastinum with a big piece of pot roast right here. And this patient had a large extravasation of contrast and a free perforation, of course. Luckily, perforation in EOE is not very common. There was an administrative data study looking at insurance claims that of more than 16,000 cases, it was found less, in 0.4%. So very, very few. In our data at UNC, we looked at 500 people and found 10 or 2% with perforations. Now, and this is an example of one of them, big rent here. You can see a hole and the contrast extravasation. Now, interestingly, for these patients, oh, maybe it was 12 patients, I'm sorry, but half were did not have a prior diagnosis of EOE. 9 of these occurred with a food bolus impaction. Many did not occur in the community, and none actually were related to a dilation, but some people had prior esophageal dilations. And the Spanish group, they did a systematic review and meta-analyses. And I know that Dr. Mielke is going to mention this just briefly, but I just want to point out that the vast majority of these people were either not of 70 patients with 76 perforations, the vast majority were either not diagnosed with EOE or were untreated. And you can also see here that well, 2/3 could be treated non-operatively, a third needed surgical treatment, and some were treated with stents, very few with clipping. And then with the surgery, there's a number of different techniques. So this is not common, but this emphasizes the situation where this occurs and is in a food impaction in an undiagnosed patient, which exactly goes back to being careful when you try to remove the food from patients who are coming in the first time. So this is an example of one paper from Dr. Brednord's group, where you can see a food impaction here. After it was cleared, you have the perforation. A stent was put in here. There was a lot of tissue ingrowth, so they had to do a stent and stent technique to move it out. But here's an example of one successfully treated with a stent. Now, I think when we're considering endoscopic treatment for these complications and perforations, most people can be treated, non-surgically, conservatively, and not even sometimes with stenting. I think the stenting is possible. I think we have to have a good helping of caution with this. There's only, a few cases of stenting in the literature, and one of the issues is the stent size. The esophagus is going to be fibrotic and narrow in a lot of these patients, and the stents may be too large, especially the flanges at the top where they flare out. And so you have to see what sizes you have, and could an overly large stent actually extend the injury? So that has to be thought about. Clipping devices haven't really been studied very much, and I worry for different clipping devices, again, with the esophagus wall being so fibrotic, can you actually get purchase? Could you suck up tissue for some of the more advanced devices? And then again, I mentioned this already, know the setting, food impaction, previously undiagnosed case. This is very, very unlikely with a careful dilation approach. So to bring it back, I wanted to show you this treatment management algorithm, which is a little different than the ones that we usually think about for EOE. And I'm thinking now about breaking up my treatment in EOE more into anti-inflammatory therapy and fibrostenotic therapy. And we've heard all about the anti-inflammatory therapies, and fibrostenotic therapy is dilation. And I think this kind of concept indicates that you have to consider whether both of these are needed, because in certain patients, one or the other alone is not going to be adequate. And so especially for patients who are getting, for example, anti-inflammatory therapy, if there are ongoing symptoms or strictures appreciated, they've got to move over into this arm and have that dilation to fully get rid of their scar tissue and open up the esophagus. So in summary, a careful endoscopic exam is needed to assess the findings and potentially decrease rates of complications. Most endoscopic complications are from fibrostenosis, food impaction, strictures and narrowing and dilation, and then perforations are very rare. I think dilation is really an important aspect of EOE treatment. It can be done safely upfront or after initial treatment. And this dual treatment framework, I think can be useful. Hopefully, if you use anti-inflammatory therapy and have people in remission, that will decrease the need for future dilations in the stricture patients. The very last thing I'd mention is please check out this website, egidpartners.org. This is a patient-powered research network. It's a global registry for patients with EOE and other eosinophilic GI disorders. Please have your patients check it out. It's run here out of UNC with multiple collaborators and multiple patient advocacy groups who help us do this. It is in English. I apologize for that so far. We're working on expanding it and making it more internationally friendly as we can get more funding. And we're also looking for people without EOE to be controls on here. So please check that out. And thank you again so much for the opportunity to talk.
Evan, thank you so much for this excellent presentation. As always, it's always thrilling to listen to you and to see all these practical examples that you have shown from your own clinic and your own experience. I think this is very important to learn from this. Thank you very much. This was very impressive. You have, as expected, you have a lot of questions in the Q&A, and I think they are all important. So I would like to work through them, all of them. So the first one was, what's the risk of perforation after having biopsies of crepe paper mucosa?
So I don't know that we know the direct answer to that. I think the concept crepe paper mucosa was described as a fragility of passing the scope. I actually think in retrospect, it's probably passing the scope in patients who have narrow esophagus that we hadn't recognized, and it's actually a dilation effect. So I don't think there's, I think it may be a little bit elevated if you're not recognizing there's narrowing, but I think if you're doing a careful exam, it probably isn't much elevated.
Great. What do you think of overtube use treating bolus impaction?
I think in EOE, you've got to be really careful. The overtubes are huge. And I think most people with EOE, you cannot get an overtube into. And so the practice now at our center is and this has changed over the last number of years, but we almost, if we can, we try to intubate everybody for airway protection. And then we don't have to worry about trying to force an overtube into a narrow esophagus.
Yeah, that's important. Great. Savari versus balloon. What do you recommend? Depends on the personal experience, or what are the data?
It does. So they're both safe, and there's plenty of papers on balloon, wire-guided bougie, and unwire-guided bougie. I will tell you that when I first started doing dilations in EOE, I was probably 80% balloon at least. And now I'm probably flipped to between 50 to 60% bougie. And there's a couple of reasons for that. I use the balloons if I'm really being very conservative and I don't know the diameter, or if there's a very focal stricture. But I see, part of this is my practice too, but I see a lot of people with very complicated strictures, narrow esophagus, very narrow esophagus. And I find the bougies, especially the wire-guided, the savories, to be very useful. I find them to be efficient. They do a very nice job at picking up strictures in the proximal area that otherwise get missed. But it really, I think, is a personal preference. But you got to listen to your patients, because if you're dilating them with a balloon distally and they're still having dysphagia, there's probably something that the balloon isn't getting.
Okay, now that's a tough one. How to decide again, based on the level of impactation, when to push and when not to push the bolus?
Yeah, it's tricky, and it really, I'd be interested to hear your guys' thoughts too. But for me, if I'm doing the endoscopy and the bolus is just wedged in there and I can't get the scope even a little bit around to see what's behind it, I end up trying to remove it from above, or at least enough of it that I can get the scope around. If it's and sometimes the other thing that happens is sometimes you encounter the food at 20 centimeters or 25 centimeters, and you don't know if there's another 10 centimeters of food behind that or not. And so that's why I'm doing, I guess, a little bit less of the pushing these days.
Yeah. What about injection of steroid post-EOE dilation, or any role of injection as?
Yeah, it's a really interesting question, and there's very little data on that. That data the paper that I showed you about the stricture distribution, we reported on about, I don't even remember, somewhere around 15 cases where we did triamcinolone injection. And I think as many people listening would know, the data on triamcinolone in esophageal strictures is really sort of a wash anyway. There are randomized trials where it does not seem to give benefit. There are a number of series and personal experiences with people who have an amazing response to it. I will do it sometimes if it's a really focal fibrotic stricture, and I inject after the dilation. There has been no reports yet of actually injecting steroid for treatment of EOE as an anti-inflammatory effect. Yeah. But I think for strictures, again, you would use sort of the same clinical judgment for triamcinolone that you would do in any kind of stricture.
All right, here's one question on how long the effect of dilation lasts.
Part of it depends on the severity of the stricture, but the data from Dr. Schofer's paper with the Northwestern group in collaboration showed that on average it was at least a year with their dilation, and so it can be very long lasting. And some patients just end up electing to do a dilation every so often for their therapy.
Okay. And here one last one: do you dilate even if EOE dysphagic patients does not seem to have any visible strictures?
It depends on
what about narrow lumen esophagus?
So narrow lumen esophagus for sure, I dilate those. Yeah. If a patient doesn't have a visual stricture, it really depends on the clinical scenario. It may be a patient who has had a lot of different treatments and they still have dysphagia, or they've had food impactions. If someone has had a food impaction, I almost always will try to dilate them. But again, I now have it in my mind that I may miss half or more strictures if I'm only thinking visually. So I don't dilate everybody as a rule, but I think about, do I need to carefully measure this esophagus?
All right. I think with respect to time, we have to move on. Thank you very much again, Evan, for this excellent presentation and this intense discussion. Thank you very much, and take care. So with that, I will hand over to Eduardo.
Great talk, Ivan. Thank you. And now is my co-chair turn of talking. He already presented himself at the beginning of this webinar. Anyway, Stefan Michalke is working at the Center of Digestive Disease Internal Medicine Center, Eppendorf, Hamburg, Germany. He published more than 150 papers, and some of them, of course, are on eosinophilic esophagitis, and he contributed a lot, improving our knowledge about treatment and about steroid treatment specifically. And so it's a pleasure to me introduce him, and the title of his presentation is Advances in Medical Therapy of EOE. Can we prevent disease progression? Please, Stefan.
Thank you, Eduardo, for the kind introduction. And yes, this is my title, and I would like to point out that I'm not talking about elimination diets, as it says in medical therapy of EOE. And the focus of my presentation really is not how can we achieve remission. I think we should move beyond that, because we know that we have to deal with a chronic disease, and this has been pointed out by the previous speakers as well. So in this respect, the focus of my presentation is, can we prevent disease progression? Because this is also what we need to do in these patients. Now I have to move on. This is my few disclosures. Now, you have seen this cartoon multiple times during the symposium, and this really points out the natural cause of this disease, going from an inflammatory state over time to a fibrotic state. The problem is we don't know in the beginning, when we have a new patient with EOE who has maybe only inflammatory signs in the esophagus, whether or not this patient will move on to the fibrotic state. Based on the studies that we have seen, and you have seen it multiple times today, we have to assume that almost any patient will go this way if the patient remains untreated. And this has been shown by this first Swiss study. We have seen today several times that basically all of these patients went to a fibrotic state over time when they are not treated. But I also would like to point out the first column here, even patients who have a very short history of symptoms, 0 to 2 years, the first manifestation is on first endoscopy, almost half of these patients already have fibrotic signs in the esophagus. So they already have signs of progressed disease in the very beginning, even if they have a short medical history. And this is important. So that means that in any new patient that you have in your endoscopy or in your practice, you have to think about progression, and you have to think about prevention of progression, not only about short-term remission. This is important. And this you have seen the increase in relevant strictures in the esophagus over time if patients are not treated well or not treated at all. And this has been confirmed by this very large study from the Netherlands. This has been shown by Arjan Bredenort as well. Again, the same finding, fibrotic features will increase over time when patients are untreated. Inflammatory features will decrease over time, and the complications, food impaction and strictures will also increase over time. So this has been confirmed by 4 large cohort studies now, and also important, and this has been addressed by Evan Dallin in his presentation, even if you have a patient with known EOE and you lose this patient, so the patient is not coming back for follow-up, a medical gap, and this has been shown in about 100 patients here in this cohort from Evan Dallin's group, that this is not good. And they defined a medical gap as at least 2 years without medical contact. So no follow-up, no check for treatment adherence, etc. And if these patients have a medical gap, then the disease will progress again. And all features you can see here, exudates, rings, furrow strictures, will increase significantly if the patients fall out of follow-up of medical contact. So this is important. And this was also time dependent. The longer the medical gap, the higher the number of strictures. So this emphasizes that it's a chronic disease. And even if we have made the diagnosis and we have treated the patients initially successful, it still remains a chronic disease. And that means we have to think about long-term treatment. We have to be as effective as possible with long-term treatment to avoid this progression and to avoid complications. And this, just to highlight again, Evan Dallin has shown this in his presentation, that perforation is rare, but it's very severe complication of EOE. And again, in most of these cases, the diagnosis was not known at the time of perforation. The perforation was the first clinical manifestation of their disease, and the other third of patients were either untreated or not effectively treated. So we have to keep these data in mind in any patient we see in our practice, any new patient, that this could happen. It's rare, but it can happen. And as you can see, most of the perforations occurred during bolus obstruction spontaneously, and the other perforations basically were the result of endoscopic interventions, bolus removals, dilations, biopsy sampling, poorly tolerated endoscopy. This all can happen to or lead to such rare complication. And these are just a few samples after the systematic review published this last year and the year before. And this again highlights how important medical follow-up is. This was a 50-year-old man, a doctor himself. He had EOE for 14 years already, but no medical follow-up. And during lunch in the hospital canteen, he experienced an acute severe bolus obstruction with perforation here with free air in the mediastinum. And this patient was treated immediately in the same hospital by esophageal stenting. This is another case, a younger man with EOE since age of 9, treatment only symptom-oriented, no follow-up for 10 years, so no regular endoscopic and histological follow-up. And this patient experienced also acute bolus obstruction after sandwich dinner, and yet even cardiac arrest during this bolus obstruction. Reanimation was done successful, but then he had esophageal rupture and he needed esophageal resection. So this is a very severe complication of this disease. And here another case with the esophageal pleuropistula before the diagnosis of EOE. So this just underlines that severe complications can happen in this disease. It's not a trivial disease. And this is important if we think about treatment goals and understanding treatment response. What are our goals in these patients? Of course, in short term, we want to have ideally complete normalization. Response is fine. We have discussed this. What does it mean in terms of histological response, etc.? But ideally, as in other chronic inflammatory bowel diseases, we would like to have complete normalization. So ideally, no eosinophils or less than 6 eosinophils in the esophagus, a significant symptom resolution of more than 90%, whatever metric you are using, and ideally a normal esophagus with an EREF score somewhere below 2, so 0 to 1 would be acceptable for the definition of endoscopic remission. So this is a short-term goal we want to achieve with our treatment, whatever we start with. But we also have to think in the same patient at the same time when we start treatment, we have to think about long-term goals, because many patients will have relapse when we stop the treatment or take the treatment away. So we have to think about maintaining remission, long-term remission in these patients. We have to, ideally, if we can, we have to, or we should goal for reversal of fibrosis. We want to prevent new fibrosis in the future, progression of disease, prevent complication, and normalize quality of life of this patient. So this is a huge bundle of treatment goals that we have in these patients and that we have to keep in mind when we have new patients in front of us with EOE. Now, can we achieve this? These are older data from the Swiss EOE database. This was at the time when we have asthma drugs were used to treat EOE, but these patients were treated for a median of 5 years and with a lot of intensive follow-up visits, over 800. And as you can see, patients really do better when they are treated long-term with topical corticosteroids. In terms of clinical remission, endoscopic remission, histological remission, and even complete remission was significantly higher, the proportion of patients when they were exposed to topical steroid as opposed to no steroid treatment. But as you can also see the numbers here between 30 and 50%. So there's still a lot of improvement. But again, this was at the time when there were no approved drugs for the treatment of EOE. But the patients have certainly a benefit from this kind of long-term treatment. And this was also from the Swiss group, from the same patient cohort. They were also able to show that you can actually reduce significantly the number of bolus obstruction when patients are on topical steroids. And the longer the time they are on topical steroids, the lower the risk for bolus obstructions. So now this was the old era, which I like to call it, because we have now novel EOE-specific topical corticosteroids, which were specifically developed and designed to treat inflammation in the esophagus, as opposed to asthma preparations that we used in the past. And basically, these are the three players in the game: the budesonide oral dispersible tablet, the budesonide suspension, which was studied in the US, and the fluticasone orally disintegrated tablet. So all preparations specifically designed to treat inflammation in the esophagus. And as you can see, for all these preparations, phase 2 and phase 3 studies has been done or are ongoing. And I would like to point out on this in my presentation, because this is the future what we have to use in these patients. Now, this is a phase 3 program with the oral dispersible budesonide tablet. And in this phase 3 program, almost 270 adult patients were included. And these patients really had chronic disease. They had dysphagia for a mean of 10 years. Nearly every patient in this cohort had bolus obstruction in the past. 15% had dilation. And then these patients were included in this program beginning with induction of remission therapy with 1 milligram BID for 6 weeks. And there was an open label extension. If patients were not in clinical remission at 6 weeks, they could extend to 12 weeks. And then there was another arm with open label induction of remission with a larger group of patients, with 181 patients who were treated for 6 weeks for induction therapy. And patients who went into clinical histological remission were then entered into a maintenance treatment phase in this program with a double-blind maintenance remission therapy over 48 weeks with 2 different dosages of budesonide compared to placebo. And then patients who were still in clinical histological remission at the end of this year, they were entered then in an open label extension phase for maintenance of remission for another 96 weeks. And fortunately, we now have already data from this part of the study, so we can really make a judgment and share the experience with this kind of long-term treatment. And as you know, this drug was the first to receive approval in Europe in 2018, and it's now available in many European countries, UK and Canada. And we have experience now since June 2018, so since almost 4 years, and I can tell you that this drug was really a game changer in our clinical practice and how we treat the patients today. And these are the key data from these studies. Here, the 6-week induction, the percentage of patient in clinical histological remission with very stringent criteria was almost 60% versus 0 with placebo. And if patients continue treatment for another 6 weeks, the rate of clinical histological remission went up to 85%. So it's a quite effective drug. And if you look at the histological remission in the different esophageal sites, the proximal, mid, and distal segment of the esophagus, you can see a histological remission rate over 90% in all parts of the esophagus, indicating that the drug is really getting there where it's supposed to work. And even the endoscopic remission data or the endoscopic remission response data in this trial were quite impressive. Here, the clinical histological, these patients who achieved clinical histological remission in week 6, you can see that the EVER score significantly goes down from 3.6 to below 1, and of course, mainly driven by the subscore of inflammation, but also, and this is very important, also the subscore of fibrosis improved significantly over time in these patients who were in remission at 6 weeks, and also in these patients who get into clinical histological remission after 12 weeks, the fibrosis subscore significantly decrease down to 0.3 after 12 weeks of treatment. This was highly significant. So this is an indication that we can really reverse fibrosis in these patients when we have an effective treatment modality. And this was confirmed by the larger group with the open label induction study, which was published a couple of weeks ago. Again, 181 patients with 6 weeks treatment of 1 milligram BID with the oral dispersible tablet. Again, 70% clinical histological remission, 90% histological remission, and this was again seen in all parts of the esophagus. So we have a lot of confirmation now that this particular drug is highly effective in treating EOE, and these are figures you cannot achieve with elimination diet, you cannot achieve with PPI. This is impossible. You can only expect this if you do elemental diet with formula-based diets which are not really available in clinical practice and are very cumbersome. So this is extremely effective, and this is what we have now in our hands to treat these patients. And here the curves you can see with the clinical response, the patient assessment, the ESI-Pro, they go all up in the same line. So it's so the patients really benefit, and we are able to maintain clinical remission in most of these patients using this drug. This was the one-year maintenance trial, the placebo-controlled trial, where we saw that we can maintain clinical histological remission in 75% of patients, no matter if we use the higher dose or the 1 milligram BID or the 0.5 milligram BID. There was a stable maintenance of remission using both doses. But more importantly is the placebo group, because the placebo group tells you what happens if you withdraw your drug, if you take away the successful induction therapy, which led to clinical histological remission. If you remove this treatment, then most of the patients will have a clinical and or histological relapse within 1 year. So it was more than 90% in the study. And as you can see here, this is just clinical remission. And if you look at the placebo curve, what happens after withdrawal of the drug, that 60% of patients will experience clinical relapse within 1 year. But here we have more than 90%. This is because over 90% experienced also histological relapse, but only 60% had clinical relapse. That means that there's a difference, a delta of 30% of patients who already have histological relapse, but they don't have symptoms. And this is also a strong argument why we have to have follow-up on these patients. We have to do an endoscopy after 1 year to check if the histology looks good and not only rely on symptoms. And these are data from the first year of the open label extension part of the trial, where 168 patients were further treated for another 48 weeks, most of the patients with the 1.5 BID dose. And as you can see here, clinical remission was maintained in the majority of patients, deep histological remission in 48% of patients, and the patient's global assessment of disease activity even improved after continuous treatment. So this is very convincing data that this treatment is highly effective to maintain remission in the majority of patients. And even more importantly, all patients which entered this trial, they had no further bolus obstructions, no need for dilations, and this with a very good safety profile. And there was no change in the favorable safety profile over time. And this year at UEGW and DDW, you will see the 96-week data. I don't have a slide yet, but I can tell you that these figures remain the same. So there's no change even in long-term treatment over 96 weeks, over 3 years in total, with respect to efficacy and safety with this treatment. Now, what about the other steroids? This is a budesonide oral suspension, which has been studied in the US, the ORBIT trial. This is a phase 3 trial, which included 380 patients aged 11 to 55, and they were treated with 2 milligram BID of this suspension versus placebo for 12 weeks. And here this was a co-primary endpoint consisting of a stringent histological response, again, less than 6 EOS per high power field, and this was achieved in half, on 53% of the patients, and almost in no patient in the placebo group. So very highly significant response with the suspension for induction, and also dysphagia improved significantly here using the DSQ score. There was a significant difference between the active and placebo group after 12 weeks. And then there was a long-term treatment part in this study where patients in remission were treated further with 2 milligram BID for another 36 weeks. This was a kind of withdrawal trial with including 48 patients, so only a small proportion of patients which entered this extension study, and about half of them received further budesonide 2 milligram BID, the other half placebo. And here you can see in the ITT analysis that there was a difference, a numerical difference between the two groups, but it was not significantly different. It's probably a matter of sample size or other reasons. Nevertheless, the FDA rejected this drug, and as far as I know, the sponsor of this drug has exited the strategy to develop this any further. Maybe Evan can comment on this because he was very actively involved in this program. And the third one is the fluticasone oral disintegrating tablet. And there was a phase 1/2 trial previously published, and this is the phase 2b trial, the flu trial, including 106 adult patients who were treated with this fluticasone tablet in 4 different dosages. You can see here 3 milligram BID, 3 milligram at bedtime, 1.5 milligram BID, and 1.5 milligram at bedtime and placebo. And this was a 12-week induction trial followed by a 40-week maintenance trial. And here you can see the primary endpoint histological response with stringent criteria at week 12, and all 4 groups were significantly better than placebo. And this was maintained over time. Here, the histological response at week 26 and week 52. So this was maintained in the majority of patients, indicating this drug is also very effective for short-term and long-term treatment of EOE. And here you can see the improvement of this dysphagia episodes in all 4 active groups. This was a significant effect. And also the endoscopic appearance, the ERAS total score, significantly improved over time in these patients. So this has fast-track designation, this drug, and the phase 3 trial, the FLUT-2 trial, is currently ongoing, and I think next year we may see some highly interesting further results on this drug. So based on all the experience that we have today now on topical corticosteroid therapy in this patient, the published data, this is just a recommendation and the conclusion of the AGA guideline, which was recently published. And as you can see, there's a big difference between the strengths of recommendation between topical corticosteroids as a group and, for example, PPI or 6-food elimination diet over no treatment. And the quality of evidence also is very different between these 3 strategies. So in my view, this is the treatment of choice now in these patients because of the quality of data and the strengths of recommendation that we have now in different international and national guidelines. So this should be the treatment of choice that we offer these patients first line. Now, there will be new treatment targets in the future, and this is just the immunopathogenesis of EOE, showing the key cytokines that are involved in this disease, namely IL-13, IL-4, and IL-5, for example, and with the respective receptors. And these are important treatment targets in the future. And this has been shown by the dupilumab trials. Dupilumab blocks IL-4 and IL-13, and this is highly effective in these patients, as shown in a phase 2 trial with 47 patients, which were treated with 300 milligram subcutaneously weekly for 12 weeks, and all of the key endpoints in the study were significantly improved by dupilumab versus placebo. Symptoms, eosinophils, ERAF scores, histological activity, and also endoflip data was significantly improved under treatment with this antibody. And this is the phase 3 study, which has been presented by Evan Dellen at 2 years ago in the European meeting, with 81 patients treated for 24 weeks. Again, significant improvement of dysphagia very early after the first 2 weeks, already a significant improvement of symptoms, a stringent histological response and attractive histological remission dates, and also an improvement of endoscopic experience and the ERAS score, and this with a very good safety profile of this antibody. So this will be also a drug that will have in the future to treat EOE. And last year on the European meeting, Evan Dellen even presented an abstract on 77 patients who received further treatment for another 28 weeks. So continuous treatment with this antibody, showing that these remission rates are stable. The efficacy of this antibody remains stable over time. So this is very promising data to me, especially for patients who are not responding to steroids. We have to offer them something, and I think this can be something in the near future that we will have in hand to treat these patients. Now, another antibody which is quite far in the development is RPC 4046. It's now called cendakimab. It's an anti-IL-13 antibody. This is the phase 2 data with nearly 100 patients with 2 different doses, treatment for 16 weeks. And again, significantly responds to this antibody when it comes to reduction of eosinophils, histological remission, and ERAS scores. There was an advantage for the higher dose when it comes to change in the DSQ score, the symptom response, and this is the reason why the higher dose is now further studied in the phase 3 program. But in this phase 2 program, 66 patients even continued treatment with these antibodies, the responders, for another 52 weeks. And as you can see here in these lines, that the response to this antibody was stable over time, over 1 year, when it comes to histology, symptoms, and even endoscopy. So this is very promising data for the future. And there is even more to come up. Candakimab is in phase 3 now, as I just mentioned, but there are other antibodies like benralizumab, mepolizumab, anti-IL-5 antibodies, which are now in phase 2 or phase 3. So there's a lot in pipeline which we will see in the future, maybe becoming available for the treatment of EoE. With that, I would like to conclude that EoE is clearly a chronic inflammatory, potentially progressive disease. I think, and I hope we have convinced you today that this is the case. And with effective anti-inflammatory therapy with novel EoE-specific topical corticosteroids, we can induce and maintain long-term remission in this patient, and we will be able to prevent disease progression and complications. And also long-term therapy with topical corticosteroids is safe. We have a bunch of data also on safety data, and there is no big concern to use these drugs long-term in these patients. Novel biological therapies, as shown a minute ago, have shown efficacy and safety for short-term and even long-term treatment of EoE, and hopefully will become available in the future. Thank you very much for your attention.
Thank you, Stefan. Really great talk. And indeed, the development of these steroids for EoE, for oral dispersible disintegrated tablets and so on, was really a game changer for the treatment of this disorder. There are, of course, some questions for you. And do you prefer prescribing, or this is, I mean, probably is a question before the trial you showed has, do you prefer prescribing oral dispenser steroids or inhalers for refractory eosinophilic esophagitis?
Now again, we have now this is a tablet available for 4 years now, and I don't even recall the time before, but of course we used some asthma preparations. I think the budesonide suspension, this is what I mainly used, Pulmicort, but it was cumbersome for the patients because insurance issues and who will pay for that and these kind of things. So this was really painful. So as you said, now with the new options that we have, these are really game changers because they standardize treatment, they make it much easier to deliver this treatment to the patient and so on. So this has really changed not only the game in clinical practice, but it also changed the course of disease.
May I ask you if you start with PPIs and then move to steroids, or you just start with steroids?
I have to be honest, in most cases, I start with a steroid right away because especially if I see fibrosis in the beginning, and this is quite common as shown in these large cohort studies, and if I do see rings, if I do see even a mild stricture, whatever, I start with steroid right away. I think there's no point in starting with PPI in these patients, especially as it has been shown by the Spanish group. If the patient has strictures, the PPI response is even less than in patients with only inflammatory signs. So in most of the patients now, I start with a steroid right away because it's the most effective treatment, and I cannot see any reason to keep this treatment from the patient and offer a less effective treatment, which is not approved. So this is really a conflict for me.
Sure. But I come to another question from another person. Are there concerns with long-term effects or topical steroids? Any side effects in the long term, of course?
Yeah, not really, based on the data that we have now, not only with the oral dispersible tablet, but also from large cohort studies. For example, from Swiss, the 5-year study that I have shown you, the rate of local candidiasis was 3% in this trial. And this is usually mild candidiasis, so this is not a big deal. If this happens in a few cases, less than 10%, you just treat it topically and that's it, and you continue steroid treatment. So there's no risk for severe local side effects. And with respect to serum cortisol, so systemic effects, we have seen in the phase 3 program there's no change in the serum cortisol levels over time, even after 3 years of treatment.
The same is true for the children?
Yeah, and in children, it's a little bit different. I know that pediatrics have more concerns about initiating steroids from the beginning, and when it comes to long-term treatment, with respect to growth in these children, that's a little bit different story compared to adults, and they are a little bit more reluctant to use steroids. But in the end, it depends who you talk to. A lot of pediatricians are using steroids as well.
But you already partially answered to this question. Is there an increased risk of esophageal fungal, and you already answered, or viral infection? We
didn't see any case of viral infection in the patients in the phase 3 program, and also in my clinical practice. And I have now about 230 patients on oral dispersible maintenance treatment, long-term treatment. So that's a huge cohort, and we have never seen any viral infection. And again, the rate of histological confirmed local candidiasis in the esophagus is about 5%.
Very low, yeah. Any role for combined full dose oral PPI and swallowed or budesonide in EOE?
I think not from the beginning in any patient. I think you should start with one treatment, because when you start with two and the patient is in remission, you're not sure if this is a steroid or the PPI only, and you cannot answer this question. So I don't see any advantage to start with a combination. Different story is when you start with one and you have only partial improvement or partial response, then you can think about combining, but not in any patient in the very beginning. I think you should start with one. And there are patients where you can start with a PPI, of course. If you have patient with just inflammatory signs, more in the distal esophagus, not a pan-esophagitis, this would be, for example, a patient where it's justified for me to start with a high-dose PPI. But again, follow up. This is very important.
One practical question: does budesonide work better if taken between meals?
We don't know. It's recommended to take it after meals, because once you have administered the table or any other suspension or whatever, the patients are not supposed to eat and drink for at least 30 minutes to increase the contact time of the drug with the esophagus. So it does not make any sense to take it in between the meal or whatever, or prior to meal. So they should take it after meal, and then they should stay fasting for at least half an hour or an hour.
One important question that patients usually do, eventually, how long is going to be the duration of steroids maintenance treatment? Lifelong?
I always try to avoid the term lifelong, because this is only for jail or something. This is a chronic disease, and you have to think about treating a chronic disease like you think when you treat ulcerative colitis or Crohn's disease or asthma. This is the same thinking. This is a chronic disease. This has been shown multiple times, also in this symposium. It's a chronic and progressive disease. So we always have to think about long-term treatment. There's no point in hoping that after 12 weeks, the story is ended. So if you stop treatment, most of the patients will relapse. So you have to think about long-term treatment. And I always tell the patients when they ask this particular question, I always tell them, as long as the disease is there and it's active, you need treatment. This is something you would also answer the asthma patient, right?
Right. And there are other questions about side effects. So probably we need to stress more that there are no side effects up to now.
Yes.
There is a question: do you actively monitor for adrenal suppression or bone density loss in some patients with long-term budesonide treatment?
We don't monitor for adrenal function, because we have seen now the serum cortisol level over 3 years now and nothing happens. So I think there's no basis to recommend this in adults. In children, it's a little bit different, as far as I know from pediatricians, but in adults, there's no recommendation or no need for monitoring. With regard to osteoporosis, we don't know. We have included also bone metabolism markers in the phase 3 program in the urine and blood, and there was no change at all. But we don't have any data from densitometry or so. But I don't expect that anything happens in the bone.
Another important question also from my clinical practice, should we keep all the patient on maintenance treatment or long-term steroid treatment?
Yeah, I mean, this is the key questions we don't know. We didn't know even other like Crohn's disease in the beginning when TNF alpha came, the same questions came up. How long should we treat this patient?
Sure.
And then you do withdrawal trials. And we have one withdrawal trial from the Swiss group with a small group of patients in deep remission over a long period of time where they took away the steroid, and 80% of these patients experienced relapse within 1 year or so, or 2 years or so. So I think and it always helps if you look back how long the disease was already there. If this patient had dysphagia already for 10, 15 years with 2 or 3 bolus obstruction before diagnosis, then you can presume that this is chronic disease. Even if you have this treated successfully, it still remains chronic disease. And this should be the way of thinking in long term when you treat these patients.
Another important question, how frequently do you require upper endoscopy with biopsies for follow-up during maintenance treatment?
Even if the patients do good and they are free of symptoms, I scope them every 1 to 2 years, depending on how long they are already on stable maintenance therapy. The first endoscopy, follow-up endoscopy is after 1 year in my clinical practice. And if they are perfectly fine, the next one would be after 2 years. Or in case of recurring symptoms or everything, or something is wrong or something, but otherwise after 2 years.
And what about the dosage? You start with 1 milligram or more? And
the induction doses is 1 milligram BID for induction of remission. And once you have achieved remission, then most of the patients do fine with 1 milligram BID. In some cases, you have to increase from time to time because they have recurring symptoms, or even on follow-up, a little bit of histological relapse, but not that high compared to the beginning. Then you can discuss increasing the dose for a couple of weeks, and then you go down again to 1 milligram.
How can dupilumab and the other biologics will change the long-term treatment algorithm?
That's a very good question, because when you break it down to how many patients will need this in a country where, for example, the budesonide oral dispersible tablet is available, if you have 85% remission in the beginning, so you have only very few non-responders, and most of the patients tolerate it quite well. So the question comes up, who is the group of patients who will be eligible for treatment with such an antibody? This is a very good question. I'm sure the group is not that big, but they exist. So we have steroid non-responders, and they had also PPI non-response in the past, and they are not really excited about long-term elimination diets. So I think there will be a defined group of patients who will benefit from these new treatment modalities like dupilumab or other antibodies in the future.
You already answered this question, but I want to ask you again. Do you step down the approach with treatment, and do you reduce the dose you do?
Yes, of course. Again, with the steroid, I go down to 1 milligram because this is very low dose, 1 milligram. But some of my patients even go lower. If they come back for follow-up, they said, "Oh, I just took the tablet every other day, and I'm doing fine." And then you scope these patients, and they are fine. They are still in histological remission. So there may be even patients who need even lower doses than 1 milligram per day to maintain remission. But we are not sure how big this group is. But I have also patients who reduce the dose and take the tablet like 2 times a week or so, and when they come back, they really have histological relapse. So,
do we know the rate of secondary loss of response per year?
At least from the phase 3 program that I overview, there was not really complete loss of response. That didn't happen. Sometimes you have mild relapse under 1 milligram, but then you just increase the dose and the patient respond again. So this is not loss of response. So loss of response meaning there's no response at all. This didn't happen.
Yes, secondary, I mean, during treatment.
Yes.
Yeah. And another question is more about the natural history of eosinophilic esophagitis. Any risk of malignancy?
You mean?
Any risk of malignancies?
By the disease itself?
By the disease, yes.
No, we have no data that indicate that there's a risk for malignancy. It's probably, or certainly, also because of the kind of Th2 inflammation, there's no risk for malignancy in these diseases, and we don't have any data about increased risk for malignancy, so there's no concern.
I have to admit that we did not talk a lot about diet, Stefan.
No, this is why I choose the title in the presentation.
How frequently do you use diet in your clinical practice?
Almost zero these days. When I have a new patient, I offer him the treatment options. I offer him the oral dispersible tablet. I tell them what to expect from this treatment in terms of remission rates, in terms of side effects, tolerability. I talk about PPI, high dose PPI, and I tell the patient what he can expect from this kind of treatment. And I also talk about elimination diet. And then I make the decision together with the patient. And the number of patients that I recall who said, oh, great, I start with elimination diet, 6-food elimination diet, is less than 10 out of like 250 or so. So patients, in my experience now, patients really prefer an effective solution, an effective treatment, which is easy to administer, and it has not such a big impact on their life, like elimination diet, which is, as you said, it's very cumbersome. It's a huge impact to make 6-food elimination diet in long term. The re-exposition procedure is very complicated. So this is not very attractive in the beginning.
I totally agree with you. Usually ask, do you want to continue to eat pizza, pasta, and tiramisu?
Right. Especially for Italians, this kind of treatment must be very effective because you can eat anything under this treatment.
And another question, if we don't have the oral dispersible budesonide, what dose of budesonide inhaler is recommended?
Yeah, I think the dose is the same. So if you have not available the oral dispersible tablet and you have to use an asthma preparation, the dose is the same, 1 milligram BID. This has been shown in the past by other studies using asthma preparations. So the dosage is the same. It's just a different mode of delivery with the new tablet, which makes a difference, of course, because the drug comes with the saliva to the esophagus, and this is obviously different to swallowing as some kind of liquid or suspension, because the contact time is probably increased by with the saliva as carrier. And this will be shown, hopefully next year, by a scintigraphic study.
Another question is, does dilatation reduce the risk of perforation? Does steroids used before dilation reduce the risk of perforation?
I don't know. We don't have the data on this, I guess, whether the rate of perforation is reduced by steroids when you dilate the patient. I think we cannot answer this question. I think it depends more on how the dilation is done by the endoscopist. When you need dilatation, you need it. Right, but we have no data to answer this question, to be honest.
Yeah, I have another question for you, Stefan, but please let me know when you are tired.
Well, I'm fine.
And any advantage with the use of, the dexlansoprazole, or do we have any data about the use of vonoprazan and other PCABs for treating eosinophilic?
Not yet. There are no formal trials on these new PCABs or new PPIs on EOE. They look a little bit promising, but again, I don't make any promises before I see a valid trial and data, because we know the PPI data, they are very going up and down. In some trials you have 30%, in some trials you have 50%, but almost never more than 50%. I think this is a range what we can expect from PPI, and I would be more than surprised if PCABs would be much better than that. But this has to be studied in a trial.
I think so. And another management question, is there any evidence about the possibility to alternate PPI and steroids for mitigating adverse events in long term? You already answered that there are no adverse events.
These questions always come up, but the question is, why do you want to change your strategy if it's effective and safe? If you have shown this, then of course you can think about alternatives, but there's no real medical need for this, unless the patient says, I want to have less exposure to steroids for whatever reason. But from the medical point of view and from the scientific point of view, looking at these data that we have now with huge numbers of patients, there's no real medical need to think about these kind of alternating treatments. I would only do this if this is the wish of the patient and would be the companion, but this would not be my primary recommendation.
I agree, but you know, most of the time it's a problem of communicating with the patient. You have to explain them that there are no side effects and they do not risk anything. Otherwise, always they come up with the question about safety, adverse events, steroids.
Because of course, these questions are always in the room, and you have to proactively talk about the patient, about this, about the safety, about the data that we have. And this is quite convincing, and then you can take the fear away from these patients, in my experience.
And do you induce remission by 2 milligrams? And the induction phase, how long does it take?
So again, 1 milligram BID, so 2 milligram per day is the induction dose.
For how many weeks?
This depends on the endoscopic manifestation in the beginning. For example, if you have only inflammatory signs, no fibrosis, then usually 6 weeks are enough to induce histological remission anyway. You will have 90%, but even in those patients, clinical response may be delayed, and then you continue for another 6 weeks. But in those patients, you can plan for 6 weeks. If you see fibrosis, narrowing, strictures, etc., I always go for 12 weeks from the very beginning, and I plan the first follow-up endoscopy after 12 weeks.
Yeah, and another question about the biologics. Do you know if in this trial the patients were stratified based on response to steroids, or they were included just?
No, they were not stratified, but these patients had already a treatment history. About 70% had already steroids in the past, and PPIs and elimination diets. So these patients had a lot of treatment history already, but they were not stratified, and this was not inclusion criteria. So also treatment naive patients were able to enter these trials. So pre-treatment, except PPI, was not a condition or a inclusion criteria. But in the future, I think these trials will have to stratify in some way.
Yeah, particularly they are relevant for positioning these new drugs.
Exactly.
I want to be a little bit provocative. If a patient has eosinophilic esophagitis, but also atopic dermatitis, or which therapy?
I mean, you're right. These patients often have other atopic diseases like asthma or atopic dermatitis. And of course, if you use the oral dispersible, you do only local treatment for this one problem. And if a patient has more than one atopic disease, and maybe even a severe disease, then with such kind of treatment, you would treat 2 or 3 diseases in the same patient. And this would be an attractive option, of course. And if you have such a patient, then I think a drug like dupilumab, for example, would be a very good option indeed.
Just the last question, because
there are 32 questions in the chat. We cannot finish this.
Yeah, but I would like to thank all the people who is doing question, of course. And you know that we are going to do the Bull 3 trial.
Yes.
Then I believe that is a very, very good trial in terms of design, because as the aim to answer some of the questions that were raised today. Can you comment a little bit about the Bull 3? Also explain a little bit what is.
Well, the trial is ongoing. Currently, we have included 15 or 16 patients now in my center. This is a trial that is looking at periodic maintenance therapy over 1 year. So it's basically comparing continuous treatment with 1 milligram per day over 1 year. And the other group is periodic treatment. That means 4 weeks of budesonide exposure, followed by 8 weeks of no treatment. And this is double blind, double dummy, etc. So you don't know which group you are. And this is over 1 year. And the question is whether or not periodic treatment with the oral dispersible tablet is as good as continuous treatment and better than placebo. So this is a 3-arm trial over 1 year, and patient can enter these trials when they are in clinical histological remission. You can also enter patients with active disease because there is an open label induction treatment available in this protocol. So any patient can be included in this trial. And the question is, again, if periodic maintenance treatment is effective. It's an interesting trial.
Yeah, I think so. And I would like to thank Falk for doing such a study, because it's, of course, it's more relevant for the physician than for the positioning of the. So
I mean, it's always a good goal to reduce drug exposure, of course. But we need to identify the patients, and maybe this trial will help in this regard. We need then to identify the patients for whom periodic treatment might be enough, and as opposed to other patients who really need continuous treatment. And this is the big question.
Totally agree. So I think that probably I don't know if Thomas is still present, if we need to.
He's present and he's still smiling, so I think we are doing fine, but I think we should approach to the end now.
Yeah. And I can close the webinar. I would like to thank all the great speakers we had the opportunity to listen this afternoon, this evening. Really great information about the new and current management of eosinophilic esophagitis. I hope that all the speakers and the audience and me for sure enjoy the meeting and learn a lot about how to manage eosinophilic esophagitis. Also, we thank Falk for contributing to our webinar, and Endoscopy On Air for giving us this opportunity. I don't know if you want to say something, Stefan, but please, if you want, otherwise.
I guess I'm exhausted, but you have
the
important closing remarks, so there's nothing to add from my side. Thank you.
Have a good dinner and enjoy the rest of the day.
Enjoy the evening, everybody.
Bye-bye.
Bye-bye.